I'm Neil Chase. I'm the CEO at CalMatters. And it's my privilege to welcome you here to this beautiful space with this beautiful view of our city and large parts of Northern California. Love it up here. Um, Especially pleased to be able to have this conversation today and be with you. I want to start with our host. Luce is an attorney here at Nixon Peabody and somebody who's been a great friend of ours and a good partner. I want to let him welcome us first. So, Lou. Thank you, Neil. Let me give you this one. Thank you.
Thank you, Neil, and welcome everybody to Nixon Peabody, San Francisco. I'm Lou Sizz. I'm a partner in this office, and I practice in the area of business litigation, corporate restructuring with an emphasis on healthcare practice. Nixon has a premier healthcare practice nationwide, and we do things like regulatory work, IP, transactions, litigation, and in that area, we are fortunate to work with industry thought leaders. And so what I want to do is real quickly just connect the dots between Nixon Peabody and CalMatters. And those dots start with a person named Dan Lewis. Dan is a professor emeritus at Northwestern. He focuses on human development and social policy. And Dan has been a friend of the firm and a personal friend of mine for many years. And last year, while having coffee down the street, Dan mentioned to me that it would be great if we could connect with CalMatters and put on a program such as this. And so right away, Dan connected me to Kelly Davis and Neil Chase, and we got to work. And of course, all the heavy lifting is by CalMatters, and the light lift is Nixon Peabody. We provide the space. So I will be quickly turning over the mic back to Neil, but I just wanted to express to you our appreciation for you being here for this important topic. We, as part of the Nixon Peabody brand, we try and provide space and support and obviously services on a pro bono basis and in capacities like this to better our community and to better the community for all of you. So thank you for being here. And I'll turn this mic literally back over to Neil. So thank you.
Lou, thanks so much. I appreciate you saying that our wonderful team here is doing a lot of the work, but your ability to make the space available, to convene people, to bring in the people from your circles who we should be meeting with. This is how we do our job. It's fascinating to be leading a news organization serving 39.3 million people. And it would be really easy to sit up in Sacramento. I live in San Francisco, but we're based in Sacramento. We're all over the state. And to say, you know what, we serve such a big audience, we can't possibly interact with people individually. We're just going to send stuff out to 39 million people and hope they see it. It's the one-on-one conversations. It's talking with you about how to do this event and what's the right way to convene people who care about this issue in a meaningful way. It's the conversations we have. We consider this live journalism, right? This is not entertainment. This isn't sort of a side thing to what we do or anything like that. It is a way to engage people who care the most in conversations. And I do want this to be a conversation. That's why we're in a relatively small group, right? So that we can have the conversation during the day. Some of you know Jocelyn Weiner, our reporter who's a specialist in mental health journalism, has been doing it for quite a while. I'll let you put a number on it, many years. And is going to lead some of the conversations today a little bit later on. A little bit about CalMatters. Many of you, I think, know us. I will introduce a couple people from our team. Kristen Go, who's our editor-in-chief. The aforementioned Kelly Davis, who runs our donor relationships and was a big part of making this event happen. Brendan Madison, our development manager. And a couple other people who I think are still guiding folks in from the lobby. We are a nonprofit news organization. We are 9 years old. We'll be 10 next year, and we were created out of a sense that what's happening in Sacramento is so important. Every day on the floor of the legislature, all these decisions that are made that affect our healthcare, our housing, our schools, our kids, our parents, our families, our roads, but it's all happening 90 miles up the road. A lot of people in California don't know a lot about Sacramento. Is that a safe way to put it? From a San Francisco point of view, people don't pay a lot of attention necessarily. The national debate is loud and obnoxious and takes all the attention, right? And if you are engaged with politics at all, you probably you might know your local city council member, school board member, maybe. You probably a lot of people don't know they're a member of the state legislature, unless your senator is 6'8" and stands out. You might not know him at all. Um, there's a lot, just not a lot of attention paid. And when there's attention paid, it's a little bit, and usually to the wrong things. And so CalMatters was founded to replace the journalism that used to exist. There were 150 journalists covering the state capitol just assigned to the building in 1999. And for context, there are 120 legislators. That was a ratio of more than one journalist per legislator, right? And they came from all over the state. The Bakersfield Californian had a bureau in Sacramento so that they could cover what's going on in state government, cover what their elected representatives, the people hired by the people in Bakersfield to go to Sacramento and represent them, were doing, and report that back to the people in Bakersfield, and to help the people in Bakersfield understand how all the different decisions in Sacramento were affecting all of the things there that are tied to the state. And so a number of people got together and started talking about the lack of journalistic coverage. That kind of journalism doesn't make a lot of money. It's not the thing people go to first. It's not the thing that was driving all of the traffic. I was at the San Francisco Examiner in the 1980s. My first journalism job, back when this was a raging 2 newspaper and had been a 5 newspaper town, with a lot of competition, a lot of great journalism going on, and a lot of crazy shenanigans and great chronicle headlines like "A great city forced to drink swill," right? All about coffee. People cared about the newspaper. It was part of your lifestyle. It was the thing. Everybody who worked on Montgomery Street was working New York hours, would get off work right after the markets closed and grab the edition of the Examiner that had closing stocks in it before they got on BART to go home. And that was our business. That all changed drastically in the mid 1990s when Facebook and Google came along with a better way to advertise. It's not evil. It's, shame on us for following Ben Franklin's business model for 250 years and then finding out it was out of date, right? And so the business changed. The revenue model changed drastically, but the need for journalism didn't. And so you had a market force, advertising and subscriptions, making publishers very profitable, very healthy. And you had a social need, a democracy that requires journalism to function. And one of those pieces broke. The revenue part, it just broke. It was gone. And the need in our democracy for that didn't go away. You could argue that it's perhaps more pronounced than ever. And so they created CalMatters. Simone Cox, who lives in Silicon Valley and was had run a public relations firm, came up with the idea, went to a number of people around the Bay Area and said, how do we create journalism around the Capitol? And it turned out that her Berkeley High classmate, Dave Lesher, who had been a political writer in Sacramento for 20 plus years, said, let's clone the Texas Tribune. And we in California don't like to admit anything we do came from Texas, but this one did. The Texas Tribune is 5 years older than us and a great success in doing the kind of journalism that we aspire to do. And so that model was brought here. That was 9 years ago. I've been at CalMatters for 5.5 years. I was running the Mercury News and the East Bay Times before that. And we have gone from 6 people just covering the Capitol in 2015 to a team now of 70 plus. We are all over the state. As much as it's important, I mentioned being all over the state to somebody the other day, and they said, well, don't lose the focus on Sacramento. And I hadn't thought of it that way, because you can't cover Sacramento. You can't cover what's happening on the floor of the legislature if you're not also knocking on doors in Visalia to figure out how that bill is going to affect people and if it's actually going to work, right? One of our themes for today, I'll say this before the mayor gets here, is going to be things that have passed through the legislature and been enacted and then have or have not been implemented as successfully as we might want. That's so important, to be on the ground understanding and to be talking to local leaders, not just local political leaders, certainly, but local nonprofit leaders, local everything, about what's going to actually work. And keeping in mind that even though Sacramento is 120 people who sit in Sacramento and make decisions, they come from all over the state, right? So most of the ideas introduced in Sacramento are ideas that came from somewhere else in the state. There's a few members of the legislature who've said things to me like, we read CalMatters and other news organizations to find out what's going on so that we have ideas for meaningful legislation. And of course, my reaction is, would you please write that down and tweet it so I can put it in my fundraising materials, because that's what's great for us. We are in the middle of a crazy busy year at CalMatters. We know that as much as many of us get our news from the website and from our daily newsletter, if you don't get it, we'd be happy to sign you up for it. A lot of folks get their news off the radio. We're close partners with the NPR stations all over California, and so we have a weekly news meeting with the major KQED and the other NPR stations around the state so that we can coordinate coverage. We know a lot of people still get their news off of television. And some people do, some people don't, but a lot of folks still watch TV. And I'm not talking about the extreme cable networks, I'm talking about your local TV station. And so starting May 6th, we're going to be doing 2 minutes of television every day. One of our stories done in TV format. The public television stations in Los Angeles and Orange County have asked us to do that. They're going to broadcast it. And then 5 minutes after we get them using it, we'll be knocking on the door down the street at KQED and asking them to take it too, and other folks. We're going to get that going statewide, so that we can reach more people with this journalism. It's why we do it in English and Spanish. It's why we have a college journalism network and a high school program to reach journalists at those levels, both to engage them in the profession, because we need people coming up in this profession. Otherwise, they're all going to look like me, which is not good. But we also create versions of our stories that go to libraries and schools with the kinds of worksheets and materials that the library staff can put out on a table, also in English and Spanish, and hopefully soon other languages. We do curriculum for classrooms. We do a voter guide, which is how a lot of people first encounter us, right? You're trying to figure out why we have a certain proposition on the ballot, why we're voting on dialysis again, why there are 3 propositions that all sound the same and are overlapping and confusing. We do a great job every election of explaining that, and that's what introduces a lot of people to CalMatters. And then, one more thing, we're doing the first CalMatters Ideas Festival. 2 days of in-person conversations like this one in Sacramento, panelists, individual speakers. We're showing an IMAX film that just came out about the future of cities, all kinds of fun stuff, June 5th and 6th in Sacramento. Love to have you there. We have been thinking a lot about the one area that we don't cover as well these days, which is technology. And tech is such a big story, and it's not just about, we've all lived through the days of getting a story about every cool new consumer gadget that comes out and all the stuff going on in Silicon Valley. Technology is now part of our society. It's a huge part of healthcare. It's a huge part of the mental health conversation. We just added an organization called The Markup, a technology news site that is going to bring us great technology coverage and use their technology. They do a lot of technical work to cover the stories they do to make all of our coverage better. So they've joined us. Mr. Mayor, welcome. Thank you. Good to see you. That's okay. Come on in. Grab a seat. Actually, let me ask you to sit right here. We just added the markup so that we can do better coverage of California overall, and we're very excited to be able to do that. And that's my CalMatters background, so your timing is perfect. So good to have the mayor of Sacramento here, Darrell Steinberg. Welcome.
I'm coming to talk about mental health and traffic.
This is why we decided to have you cross the Bay Bridge at 9 o'clock in the morning.
That's okay. Should have left a little earlier.
No,
that's
all right.
It's great to be here.
As someone who makes that commute often, I understand and sympathize. It's so good to have you here.
Thank you.
I appreciate you coming.
Of course.
We are gathered here today in a group of people who are leaders in mental health services, people who are active in advocacy, in legislative advocacy, in patient advocacy. I'm pretty sure you know half the people in the room because you've been involved in this issue so deeply over the years.
For a while.
And our friends at Newsom Peabody have been great to host us here to do this. I want to start, if we can, by going back to, you've been doing this a long time. This has been a signature issue of yours. I think it's fair to say the signature issue for a long time.
I would say the signature issue for 30 years. Not the only issue, but the signature.
I mean, a
issue.
mayor has to deal with a lot of things, and
Yes.
as does a legislator, as does a council member.
Absolutely.
But if you would take us back to where it was college, right, where you sort of became aware of your passion for working on issues like this.
Yes. I mean, so my story, I did not, when I got engaged in these sets of issues, have a personal frame of reference. I did not have a family story to share. I did subsequently, which was interesting because it made my point as an advocate, which is that this issue is about all of us, no matter what part of life, race, gender, socioeconomic background we come from. Mental health is about all of us. But for me, I was a college sophomore at University of California, Berkeley, and lived in Davidson Hall, the dormitory that was the dorm complex that housed the Center for Independent Living. And I became friends with a number of students with severe physical disabilities. And what awed me about them was their normalcy, how regular they were. We talked about the same things, about school, about frustration, about sports, about our favorite teams, and all of it. And I was just moved. And then I went to law school at the University of California, Davis, at a time when the law school admitted students with physical disabilities, but the facility itself was not accessible. And in my third year, I was a tutor for a couple of quadriplegic students who had no access to the moot courtroom where we practiced our trial work. They were shuttled off to a small classroom while the rest of us got to argue in front of a jury and in an authentic courtroom. And we asked the dean of the law school at the time if he would consider building a lift so that everyone could participate. And he said, of course, of course, of course. And said, we just need to get the money, put me off and put me off and put me off. And finally, I learned one of the lessons of advocacy, which is never take no for an answer. And I went over to the associate dean of the entire university and said, when can the law school expect the money for the lift? He said, I don't understand why you're asking me that question. We offered the law school the money months ago. They turned it down because they didn't want to ruin the aesthetic look of the courtroom. I said, did they put that in writing? He said, yes, they did. I said, would you mind if I got a copy of that letter? It was on the front page of the Davis paper. And within 4 months, that lift was built. And again, for me, the two people who I advocated with, since passed away, one of polio, one of the last victims of polio, and the other a star athlete injured in a car accident. These were people that were inspiring to me. And so it was this whole issue of disability and the flip side of disability being ability. And then when I got to the city council in Sacramento as a young man, and homelessness, by the way, which was an issue back then, was real, I decided that when I was a candidate for the assembly, I got some well-worn advice that I give to every young legislator. When you enter politics, pick an issue and make it an issue that no one else is working on so that you can tread new ground. And I decided I was going to work on mental health because it was at the root cause of homelessness. I had this interest in disability. And so I just decided to make that my cause.
First of all, I love your endorsement of college journalism. Being on the front page of the Aggie was the accomplishment that caused that story to be big news.
It
right?
really was. And yeah, and I learned about
You should have been a journalist. You were halfway to being a journalist.
You know, there's actually a lot of similarities between journalists and politicians, even though we're sometimes adversarial. We're not really adversarial, just on opposite sides. First of all, they're not exact.
We're not even on opposite sides.
They're not exactly favored professions in this modern era, but they're really important.
That we have in common.
And really, really important. And in some ways, the instinct is the same. The journalist is trying to make life better, and pointing out where things need to be better. And the politician, at least the good ones, want to do the same thing.
And there's still some good ones, right?
There are a lot of good ones. You better believe it. And it's worth pursuing journalism and politics because done right, it can move mountains and make real change.
Yeah, I appreciate that. Going back to when you got to Berkeley and you said you were living with people who had physical disabilities. You were probably living with people with mental challenges as well, whether it was obvious or not at the time. Does that suggest that before that, growing up as a younger person and through high school, you hadn't been exposed to? I mean, we didn't see that in society.
No.
Right?
I mean, I grew up in Millbrae down the peninsula. in the 1970s, and it was a very homogeneous community. It was middle class, it wasn't wealthy, but there was very little diversity. And but I was taught, part of my values, right, that you do your best to stand up for people who have been treated badly. And so got something in there. But it was really at Cal and at UC Davis that I just saw the impact of injustice. And I tell young people as well, you don't have to have a title to be powerful. The titles have enabled me to do uh, a lot of things, but you don't have to have a title. You just need to stand up
And want to do the work and
and
care,
want to do the
right?
work. Yeah.
You could argue that the caring drove you to get the titles, not the other way around,
Right.
right?
I think.
So a number of years, I mean, I've been in San Francisco 30 years. I have an office in Sacramento. A lot of us have seen things evolve here. I was talking to Kevin Fagan, the reporter at the San Francisco Chronicle, who's been covering homelessness for a long time, and he reminded me that as much as we all talk about homelessness and unhoused people in San Francisco, um, there have been a lot of people who've been treated. There have been a lot of people who have found housing. There's a system that is working with people every day. And so what you see on the streets is the result of a lot of work to help a lot of people who have been helped and a lot of people who still need to be helped, right? And I think we often lose track of the people who have been helped and served. This is not a system that is completely failing. It's not a system that's serving nobody. It's just not working the way we need it to. Is that fair?
I think that's right. I mean, you can't prove a negative. I said that yesterday when the big city mayors convened in Sacramento to talk about homelessness. What does it mean that we have invested, the state government, Governor Newsom, the legislature have invested billions of dollars over these last 6 years? Well, we've gotten close to 100,000 people off the streets of California. And so you never make the argument as a politician because it's not convincing. Well, look how much worse it could have been, because what people see and what they experience is what forms their opinion. They don't care about that forming. And I understand that. I'm not even complaining about it. But the fact is, we know what works. We actually know what works to help people who are out on the street. And first of all, I believe in Dr. Margot Kuchel's thesis that this is largely economic and about housing. Absolutely. There are people, we have always had people living with mental illness and dealing with substance abuse, but they've found ways by and large to hang on and to stay sheltered, whether it be with family, whether it be board and care, whether it be in single room occupancy hotels. The economics of this state and of this country have driven this huge rise, together with some terrible drugs like fentanyl and that, but it is largely economic. And we have helped a lot of people. The question is, how do we improve these systems in such a way that we are helping more people and preventing people who are living fragilely but housed from becoming fragile and unhoused?
And unhoused, yeah. Looking at the arc of the time you've been working on this, I think back to, so for instance, No Place Like Home, right? There was an initiative that was going to put 20,000 people, create permanent housing for 20,000 people. Nobody would argue that it wasn't well intentioned.
It was my initiative, so
it was yours,
well intended, but it wasn't.
And it has created housing for people, not as many as you wanted. How do we get from well-intentioned? You mentioned economic. The one power the California state legislature has is economic. They can throw a lot of money at a situation. What's missing? What's the part that we haven't gotten yet?
Yeah. So, I mean, first for me, those of you who've followed my political career, and I was the author of the Millionaires Tax, Prop 63, which has become Prop 1. And so, I've never met a revenue increase for a good cause that I didn't like. And so I am.
People say that about you.
Yes. So, they have said that, my reputation. But and so money is very important, but I've changed a little bit over the course of time, because I actually think more money is not the only answer and may not even be the primary answer. The systems are still broken. There's still too much fragmentation when it comes to behavioral health. Think about it for a moment. I could argue that we have 5, 6 separate mental health systems in California that don't necessarily coordinate or work with one another. You've got private pay for people who can afford it. You've got private health insurance, which is very, very limited because most providers don't want to take it because reimbursement's too low. You have Medicaid, which is for not for the most serious mental illness, but for mild and moderate, however, whoever the God or judge is that draws that line. You've got the public system, MHSA, or now BHSA, and Proposition 1, which are the billions of dollars to help people with more serious and persistent mental illnesses. And then you have jails, you have prisons, you have a school-based system where we're investing now $4.5 billion in trying to improve outcomes for young people. All that money is really good, and yes, it's helping lots of people, but the system is still broken, and it is still legendary, no matter what walk of life one walks in. When someone has an experience with a loved one, a family member, they say, "Oh my God, it took so long to get help. I couldn't find a practitioner or a provider. They discharged my loved one from a hospital and there was no, or psychiatric hospital, and there was no aftercare. Emergency rooms are still the main place where people get dropped off." And so I don't know whether single payer is the answer. I'll tell you, but if it was one area where I would try single payer in this country, it is around mental and behavioral health because of the fragmentation. But I can tell you one thing: a unified payment system where people can literally walk into clinic, hospital, preventive care clinic, get the help they need, and all of the insurance crap is worked out in the back room. That's where we need to move to. There are some models here, Orange County, Be Well. There are different places that have tried this, but so long as we have this fragmentation and separation between the public and private systems and fragmentation within the public system, I'm afraid it is going to continue to be unwieldy and wholly unsatisfying for people who desperately need help.
And in your list of all of the different organizations involved, you didn't even get down to the level of the 58 different counties that have their own
Oh, the
challenges,
counties.
right?
So, oh boy. So I always joke, it's just half a joke, that when I wrote the Mental Health Services Act back in 2004, and of course the counties, cities are not homeless service agencies. San Francisco is different because it's a combined city and county. Cities are municipal governments that provide police, fire, parks, utilities, all that business. We're not homeless service agencies. We don't have mental health budgets. It's the counties. So I often say, if I knew back in 2004 when I wrote this act that I was going to run for mayor 12 years later, oh my God, I might have written it differently.
Give all the money to the mayors?
Well, I might have written it a little bit different because the county issues, and look, we've forged partnership in our county now that is improving things, but oh boy, there is a mismatch between resources and responsibilities. This is happening in our urban cores mostly, not exclusively. And as mayor, one of my frustrations is that I don't really have direct access to the dollars. Now I have influence because
You know a few people.
I help write the act, but I don't have direct access to the dollars. So I'm dependent on the county systems. In my area, 3/5 of the county is outside of the city. 65% or so of the problems within the city. That tells you all you need to know in terms of the political challenges that we face. But now Prop 1, I think is, which I was wholly in support of, and I know barely passed and there was significant opposition, but it comes closer to what at least my original intent was with Proposition 63 in the Mental Health Services Act, because that was a homeless service initiative. It was based on two bills that I did in 1999 and 2000, the AB 34 and AB 2034 bills, which was integrated services for the homeless mentally ill. The common recipe: assertive outreach, intensive case management, services, temporary housing as necessary, and then permanent housing. And we showed dramatic improvements for people in the 5,000 person a year cohort under AB 34 and 2034 in 34 counties. And then we did the Mental Health Services Act. Rah, rah. It was great. It's generated $31 billion for public mental health. We're proud of it. But it hasn't been as good as it could be because a lot of that service money has not been intensively focused on the people who are the sickest of the sick. And so why Governor Newsom was motivated to do Prop 1 and why I partnered with him and fully supported it. My joke was, God, I guess I didn't write the perfect law back in 2004. After 20 years,
or the world changed a little bit.
Yeah, the world changed a little bit. But now 30% of that money has to be spent on housing and housing supports. 35% for the wraparound model known as full service partnerships. And then the remainder of the money for cutting edge prevention and early intervention, like intervening with teenagers, early psychosis identification and intervention to make sure that kids, young people with behavioral issues or family histories, that they don't have that first break. And if they have that first break, it isn't the beginning of that cycle that leads to jail and homelessness. Now the law is written better in my view, and yet I'm still worried because it is what I have found in government. It's all about implementation. You can write the greatest law in the world. It's all about implementation. Are our county partners going to be absolutely committed with the greatest sense of urgency to get multidisciplinary teams on the streets throughout California to enroll people in these full service partnerships? I've had a little issue in my town, my city, because they've got a 90-day requirement to assess somebody for 90 days. Go, well, wait a minute. I see this person coming into the daytime respite center, not every day because I'm not there every day, but when I go, I don't need to be a psychiatrist to know that this individual is living with some severe underlying problems. You just know it. 90 days to enroll in a full service partnership? No, we've got to enroll people presumptively who are chronically homeless. And then if for some reason they don't meet the requirement, well, then the county can maybe decide otherwise, but it ought to be presumptive eligibility. And that's going to be a big fight, by the way, because here's the real issue. Why isn't there greater urgency? And why aren't more people who are chronically homeless getting enrolled in these kinds of full service partnerships? Because it's really hard. And it's really hard. And it's expensive. And so I'm not saying it's creaming because the county they help a lot of people. They do help a lot of people who are really sick. But the people that are living in these encampments, that's where we need to focus at least more attention on. Otherwise, we won't be living up to the original ideal of the initiative that I wrote.
Yeah. Or the new one, right? So
the new one.
Prop 1, and you are at the tail end of your term as mayor.
Yes.
You're probably not done yet. We can talk about that. But you've
7 months, 14 days, 6 hours, and
not that he's
7
counting.
minutes.
You must have been terrified when the primary election results didn't come out right away, and you're like, no, I need an election. I need
an election.
I need a replacement.
Exactly.
But Prop 1 just barely made it, and I don't know that the governor was expecting that. I don't know if you were expecting that. Does that question whether California has the will to actually implement this, or is that a different?
Oh, I think
reason?
Well, two things. One, it was March, and so in March you have a lower voter turnout. That was
that intentional? I mean, you.
I think
put things on the ballot control when
it
it's
was
there.
intentional. I think the feeling was that November is going to be a very crowded ballot. This standing alone, that it would pass easily. Now it didn't, but I think there was another message to really get to the core of and it's what we talked about a moment ago. I think the public is cynical about whether or not the implementation of this initiative and these dollars will be done in a way to meet the urgency of the moment. They're cynical, they're doubtful, they're dubious. Now, in a way, it's unfair because of what we talked about earlier. You get 75, close to 100,000 people off the streets through homeless assistance plans and all the investments that the Newsom administration and the legislature have made. MHSA itself, I think, despite my criticism of my old initiative, I think the money's largely been well spent. A lot of people have been helped, just not focused enough on the people who need help the most. And so, in a way, it's a little unfair, but life is unfair, and politics is what it is. People want their streets cleaner, and that isn't inhumane. That just means that we need to be more urgent about intervening with people. And as I said, after Grants passed the oral argument 2 days ago, I said, look, if I were the Supreme Court Justice, this would be the standard I would lay out. I would say that society, through its governments, should have a legal obligation to shelter, house, and provide services to people who need help. That should be a legal obligation. That's part of the problem now. It's not a legal obligation. It's pure county discretion in terms of how they do it. Even with Prop 1, there's still going to be a lot of discretion. And then secondly, once that offer is made to the individual, that individual should have a legal obligation to accept the help. Period. It's common sense. Rights and responsibilities go together. And we spend so much time, and I think unfairly, on the individual and involuntary treatment and commitment, which is a real issue. We don't spend nearly the same amount of time on why government doesn't have a legal obligation to serve people in the first place. Match rights and responsibilities, and I think we'll have much greater results and help more people.
I think you've just set us up for a fascinating next couple of panels that we're going to have on these questions and some of those. I caught the "if I was a judge" part. We're not going to press you on what you're doing next, but is it safe to say that leaving the office of mayor doesn't end your caring about this issue?
Oh, it's not. I'm not retiring. I just decided that after 30 years, I was ready
for the next challenge.
For some,
well, we're looking forward to seeing what that is, I think we're going to talk more today over the next couple of panels about how we actually make this come to pass. So
I hope this was a good kickoff.
It is a great kickoff.
Some things to think about,
or first pitch, or whatever we call it today.
Whatever we call it.
I know you've got a busy day ahead. Thank you so much for coming and schlepping across the Bay Bridge through traffic to get here.
Sorry I was late, and it's really great to be with everybody. Thank you,
Mr. Mayor. Thank you so much.
Was turned to everything. Thank you.
Mr. Mayor, thank you. We wanted to we're not going to answer all the questions in the first half hour. We wanted to set the tone, right? And so I'm going to bring up Jocelyn Weiner, who a lot of you know. I know the mayor has known Jocelyn. They've both been tied to this issue for a long time. Jocelyn was at the Sacramento Bee for a number of years covering this same stuff. Jocelyn has been started as a freelancer. We liked her so much we took her on almost full time. And she has been doing our coverage for quite a while. Digging into these issues, and she sort of is going to lead the conversations we're going to have today about where we go from here. So I'm going to pivot right to you, Jocelyn, and let you take us into our first panel.
On everybody. Okay. Hi there. I'm Jocelyn Weiner, a mental health and projects reporter at CalMatters. For today's conversation, I want to focus on a super simple topic: system transformation. I'm sure we'll figure this all out in the next hour. We are at a moment of great transition and tension with respect to serious mental illness. After decades of statewide inattention and neglect, we have seen a slew of mental health policies in the past few years. Just at the state level, these include, among others, a revised state parity law, the certification of peer providers, care court, the expansion of the grave disability standard, and now the narrow passage of Proposition 1, which overhauls the Mental Health Services Act and creates a $6.4 billion bond to build treatment beds and housing, among others, not to mention what's happening locally. For some, this moment feels long-awaited and hopeful. For others, it feels frightening, like the state is moving backward toward more involuntary treatment. But for now, many of these policies still dwell largely in the realm of promises. And promises get broken all the time. What I want us to come away with by the end of the hour are some concrete ideas of how to ensure the current interest and investment in helping people with serious mental illness leads to on-the-ground change that genuinely centers their needs and voices. I'd like to start off with a short discussion of the historic underpinnings of the current situation. then talk about challenges and problems in changing the mental health system, and finally spend some time talking about where we go from here. But before that, I want to take a moment to remember James Mark Rippey. I met Mark in 2019 when he was sleeping on the sidewalk of a Vallejo strip mall. He had suffered a traumatic brain injury decades before in a horrific motorcycle accident that also left him blind. He had schizophrenia. He said to me, "They're not supposed to leave me outside. The United States of America is nice enough. They're not supposed to let this happen." Just months earlier, he had been hit by a car when he stepped in front of traffic. Months after I met him, it would happen again. Even before I and other journalists wrote about him, his older sisters made sure a lot of people knew he needed help. But when Mark Rippey died in 2022, he was still on the streets. My question today, how do we as a state do better? How do we move beyond rhetoric to actual improvements for people like Mark? The more I write about mental health in the state, the more I realize how much I don't know. Luckily, today I only have to ask the questions. And I am so grateful to introduce our brilliant panelists today. Thank you all for making the trip here. Steve Fields at the end is the short one. He's the executive director of the Progress Foundation and has worked in mental health in California since the 1960s.
No, I don't. Excuse me, I'm going to stand here.
Whatever works for you.
Flank me so I don't feel.
You don't, as long as we can hear you.
Yeah. Okay, great. Thank you. All right. Sorry.
Thank you.
I had back surgery not long ago, and this is my first venture into the world. So
Yes,
it has been an exciting venture on the Bay Bridge.
We really
I
appreciate
think I'll
it.
stay working at home forever. Sorry.
Claire Courtwright is an attorney and policy director for Cal Voices, an advocacy organization run by and for people with serious mental illness. Toby Ewing is the executive director of the California Mental Health Services Oversight and Accountability Commission. Anita Fisher has been a family advocate since her eldest son was diagnosed with serious mental illness almost 2 decades ago. And Dr. Hillary Cunnins is San Francisco's Director of Behavioral Health Services. So because we have a big panel and a lot to cover, I'm hoping we can ask everyone to keep comments somewhat succinct, and we want to leave plenty of time for Q&A at the end. But that being said, if there is something that you hear that you really want to respond to, please feel free to chime in. So to contextualize where we are today, I'd like to start by delving into our history. Toby, I'm going to start with you. Long before your current position, you wrote a report for the Little Hoover Commission in 2000, in which you called for stronger state leadership on mental health, the replication of good programs, more transparency and accountability, and I think a lot of other stuff. When you look at where the state is today, almost a quarter century later, have the issues you highlighted been addressed?
In many ways, yes, and in many ways, absolutely not. I think it's important to sort of see how far we've come. So 20 years ago, the Little Hoover Commission really had a handful of foundational conclusions. First, they recognized that there was a profound lack of public and political support for behavioral health, right? I mean, it was just, if we looked at funding patterns, the way the budget is done very differently today than it was back then.
Oh, here you are.
It's very different than our funding back then is done very differently than it's done today. And mental health was always sort of last on the list. But public understanding and awareness was also very low. And the commission itself was formed in order to elevate the visibility among what we often refer to as our traditional allies, providers, family members, certainly peers and consumers, but also non-traditional partners educators and public safety and employers and labor. And we have made profound progress in that regard. At the time, we rationed access to care. Counties were struggling under such limited fiscal realities that people would be turned away because they weren't ill enough. We still have that problem in many instances. State of California and other states had no investment in prevention. We have made foundational improvements in that area. There was no strategic emphasis on early intervention. We have turned that corner in some profound ways. So I think that nobody in California today is going to say we are meeting our goals, but we have actually made profound improvements. There isn't there is not a sector in our economy or in our community that does not recognize the importance of well-being today, and that is probably the most important progress that we've made.
Great. Steve, I'm hoping you can follow, since you started working in this field, I think, was it the late 1960s?
Afraid so.
Right. So, and you've described in conversation that the same mistakes being made over and over again when it comes to our state's mental health policies. And I want to know what you mean by this and what you think has been getting in our way all these years.
Ourselves, yeah. I echo a lot of what Darrell had said earlier. We've worked together now for a number of years, and it's been incredible to have an advocate like Darrell in the field. I started at a halfway house in 1969 in San Francisco, not because I intended to go into behavioral health services, but I was a conscientious objector in the Vietnam War draft time, and I was looking for alternative service, and I wanted to stay in the Bay Area because it was kind of interesting back in 1969, 70. And I took an unpaid job as the first counselor in a halfway house. And that's been my education. I haven't left. It's now 54 years later, and we're a kind of bigger agency now, but I got motivated to take a social change political view of the mental health system because I hadn't yet been indoctrinated about how I was supposed to think about it. Diagnostics, all the things that started to make little sense to me when I saw the lives of the people who were moving into this small 6-bed house, trying to struggle with literally the deinstitutionalization movement in California. My career has paralleled almost to the first Monday they started pushing people out of the state hospitals to now. What I want to say, though, historically, and this is important because I don't think there's enough people around anymore who've paid attention since 1969. We seem to invent new bad ideas every 10 years because there's no history that's understood or accepted. One of the common myths that I think is a basis of this is it's spread today. Policymakers believe it, journalists believe it, academics believe it, is that Ronald Reagan closed the state hospitals in the late 60s, and a bunch of people were pushed out into the community, and the money did not follow the patients. And in a way, when your first premise of the promise of community mental health is based on an error, then you start adjusting to your mistake instead of reevaluating your decision. There was plenty of money in San Francisco and the state of California in 1969 and 70. If you think about it, the Short-Doyle Act in California, which is revolutionary, still nationally, provided 90 cents on the dollar from the state for any county that would open community mental health programs. Medicaid had been passed, and as Darrell alluded to, Medicaid became a major funder of county behavioral mental health programs back then. We didn't deal with substance users because we didn't know what to do. And then there was the Community Mental Health Centers Act, national model from '64 that was updated in the Carter administration. And there was SSI, so people who are being evicted, in essence, from state hospitals where they may have lived for 10, 15, 20 years, were pushed back into communities they were completely unfamiliar with, but they had ability to buy beds in board and care type homes, and a whole new industry built up. So we were rolling in money. We didn't know what to do with it. There was, and I was approaching the discussion from trying to read as much as I could about the public policy around mental health as a community approach as opposed to an institutional one. So, it was a watershed change for mental health in California nationally. And I could not find a developing theory of what community mental health looks like, separate from institutional maintenance care. We have never yet, as a state, defined what we believe community mental health needs to look like, what its values need to be, how we think about and approach the people we're offering services to. It is still, that's the fragmentation Darrell alluded to, but it's even more severe. There is no common agreement in California around what the services should look like, how we do early intervention, how we use residential treatment and other resources as a secondary prevention model. So every county is on their own. And we'll get a little more into that later. But when you think the problem is one thing, and then you keep trying to solve it because there's not enough money, or Ronald Reagan, by the way, undermined behavioral health when he was president and eviscerated the HUD budget. Darrell was exactly right. When poor people couldn't afford housing, who was hurt more than people with severe mental illness diagnoses? We still haven't decided on what it is we want to have as a system of care.
That's a perfect segue into talking with you, Dr. Cunnins. You have a new, you're new to California, so you've got a kind of different perspective coming from New York. And you, of course, came in at a really interesting time. So San Francisco, in addition to being in the initial care cohort, rolling out CalAIM, the new conservatorship law, Prop 1, and you're also rolling out mental health SF. So what do you see as a county? What are the biggest challenges to getting things done? And all the promises that are being made around all these policies, do they feel realistic?
Thank you. So I've been here for a little more than 3 years now, so I feel like I can't claim the new card anymore. I just came from a recovery summit down the street, which is led by a group of folks in recovery from addiction. And so I just want to start out by mentioning the importance of working on substance use in this policy mix and the extent to which that needs to shape how we think about, design, implement, pay for services. The other thing I'll just say, and just to echo a little bit, I think about what Steve was saying, maybe in slightly different words, which is we really need to have a recovery-oriented system of care. This is a term that some folks use here locally, both in the substance use side of the house and on the mental health side of the house. But it really it refers to a lot of the work we, and I'm guessing a lot of you, are doing around improving access to social determinants of health, community, family, worship, employment, and importantly, and particularly here in California and here in San Francisco, housing. And so without those elements, defining what that looks like in our systems of care is really leaves the folks we are trying to support to improve their health. Without those supports, recovery, I think, is harder to achieve. So I want to just say that. I think the policy changes, which are in fact dizzying to implement, I think is a fair term at the local level. I'll just also mention, in addition to what Jocelyn just said, is CalAIM, which people are aware of as a way to pay for some benefits that have not been historically paid for in the Medicaid program or the Medi-Cal program. In terms of our routine behavioral health work and all of the providers, either direct providers by the county or contracted providers by the county, we are entirely changing the way we bill and document for care. And that is a good sea change, but it is a sea change amidst the many other programs that you mentioned. The programs which San Francisco has chosen to implement early are an important part of our continuum of care. We are excited to figure out how to implement them. We are implementing with a lot of learnings along the way, and I'm happy to take some more questions on that. But these are enormous opportunities. The last thing I just want to mention, which I heard Mayor Steinberg said just right at the end of his talk, is an idea of acting with urgency. Government is not famous for acting with urgency, as you all know. And this is certainly a time in which to act with urgency to address the challenges of both mental health and substance use, and particularly overdose in our city. And so I look for ways as a county official to act with urgency. And it is hard. And so looking for ways that government can move more quickly is really important. And we are grateful for the state's leadership in really asking us to do that.
In terms of challenges, just quickly, Dr. Cummins, I wanted to, sorry, I'll let you off the hook in a second, but like, we hear a lot about workforce. What do you, if you were to choose maybe 2 or 3 major challenges, like just bullet point, I'm curious what they are.
Workforce.
Okay.
And workforce.
Okay.
And workforce.
All right.
We, right now, Steve and I did not plan this, but I would never say no to more money, but just to be clear, but we have money in programs, both our own directly run and contracted, that are not running at full capacity. That is, they can't take care of all the people they are funded to because of a workforce challenge. And it is really serious. It's a problem nationally, not just California, but it is a particular problem in high-cost regions of the country for reasons that you all can surmise about how much social service and health workers make. And so were we to have a kind of federal, state, and local effort to recruit, train, and place a sufficient workforce to be able to run all of our programs that we are able to pay for at full capacity, would be a great move forward.
Great. So Claire, I would like to take a moment to acknowledge how fraught this policy moment is for many mental health consumers. And I'm hoping you can reflect a bit on this and specifically maybe outline some of the main concerns related to Proposition 1.
Sure thing. And I will out myself. I'm a person with serious mental illness. The organization that I work for is actually a peer-run organization. So we're run by and for people with serious mental illness. We're also direct service providers under the Mental Health Services Act. So we've been providing peer support for decades, which is mental health consumers who are in recovery, providing care to their peers who are trying to achieve recovery. So pretty similar to the substance use model. I will say that the peer community, people with serious mental illness, I have yet to meet anyone from that community that was pro Prop 1. The entire community is opposed to it, and deeply concerned about all the laws that have been passing in California. And I can give you kind of a brief overview of what they've been, and I think sort of the volume of them and the nature of them, it'll be clear why we object. So, not this last legislative cycle, but the previous, we got Care Court And some of the objections to care court by our community is that the legal standard, right, the test that you have to meet to be in a court ordered program is ridiculously low. It's not a good reason. So, there's not a lot of understanding about this. I'm an attorney, so, I'm familiar with technicalities and what they mean. But I'll give you an example. For instance, care court is not like any other outpatient assisted treatment law across the United States. One of the reasons for that is you can be engaging in voluntary treatment and still be in care court. If a petitioner feels that you're not optimally stabilized, that's unusual. Having an outpatient civil commitment order tell you where you can live, as care court purports to, that's unusual. So, and a lot of these things are legally untested, right? Folks may appeal their orders and say, I don't think this is constitutional. I think this violates other laws. So we'll see how those play out. So we had care court. And then the following year, we had Senate Bill 43, which greatly expands who can be placed on involuntary holds or conserved, placed under a guardianship in California. And again, we're seeing that legal standard become very, very low. And for those of us who have worked in the system for decades, we know that the existing legal standard prior to these changes was very, very low. So one of the, concerns with Senate Bill 43 is for the first time, anyone with a substance use disorder, unhoused or not, can be picked up on an involuntary hold, just like mental hospitals, or placed under a guardianship and, conservatorship is what it's called in California. But the conservatorship is the legal front door to be placed long-term in a locked institution. So it's really important for people to understand that conservatorships are the front door to the institution. And these are, we have really objected on behalf of the substance use community that's totally naive to these things in California, because we are talking about, taking somebody and putting them on short-term holds and making sure they can't use drugs for 77 days and then placing them under a conservatorship, which could place them in a locked facility for a year, although they're sane and sober. So that's some of the concerns there. And we're seeing, as a woman and probably the only person in this room that's actually subject to these laws, they're extremely concerning. They're very victim blaming. SB 43 says if you can't protect yourself, you can be conserved. That's now being officially interpreted by counties to say you were sexually assaulted and you failed to fight back as a person without a disability would. I mean, this is really shocking. This is, ask San Luis Obispo County. Other laws that have passed recently, last year was SB 35, which is a change to care court, which allows counties and private practitioners, when you're not notified in the case and you're not in the case, to turn your medical records over to the court. And that affects your HIPAA rights. What else was last year? Obviously, Prop 1, SB 326, which changed the Mental Health Services Act, and to make it way oversimplified, a whole bunch of money is coming out of mental health services at the county level, mostly community-based organizations that provide these services, and going into what's called housing interventions. And trust me that I'm locked in a death match with the administration about the meaning of housing and whether housing interventions is really permanent supportive housing or whether it's funding for time-limited clinical treatment facilities. But the big objection to SB 326 is they didn't raise the MHSA tax, right? So instead of putting more money into the system, we moved money around. And as a result of that, we are going to lose voluntary outpatient services funded through the MHSA. And people can debate, whether or not they feel those services are necessary or important, but they do include peer support, which is a 2,800 person workforce that is on the chopping block to actually lose that workforce because of the loss of funding to the services side of the house in SB 326. And obviously with the bond in Prop 1, AB 531, the concern there is they're building locked facilities. There's an infrastructure need for locked SUD in California. We don't have any. And so, the writing is kind of on the wall there. There's an infrastructure need to be able to implement this law. There's a lot of urgency to implement the law. So, at the last minute, that bond was amended to allow for locked facilities. if anybody tells me they're not building locked facilities, I'm going to laugh and be like, talk to me in 3 months when it's official. So, that's the concern, and then this session, there's more bills, there's SB 1184 that removes the right of a person in a mental hospital to have their capacity redetermined after an initial determine they lack capacity and medications. They're, now we're going to treat 91 days that you're incapacitated to make medical decisions and inject you with medication, which is rolling back a landmark California State Supreme Court civil rights case for us. There was a very important evidentiary rule called the Sanchez rule and hearsay from our California Supreme Court that was removed last year just from conservatorships. I could go on. This isn't even all the bills. There's a real pattern of towards locked facilities, towards quasi-unlocked institutionalization where you're under a conservatorship, but you're in an unlocked facility. The bondage is the conservatorship, and just an absolute bevy of pieces of legislation that roll back fundamental civil rights. So, I think that was a lot of talking, so I'll stop.
Thank you. That's a very comprehensive list of a lot of legislation that's happening right now. And I'm curious, Anita, what your kind of response to that is. And as a parent who has been trying to get mental health care for their loved one, do you feel the same way about the legislation that's happening? Does it feel promising, or do you share any of those concerns?
Well, as of Monday, my son turned 46 years old. His journey started at age 21. So we've been at this for a while now. And I have to feel hope for these bills and these changes that I've advocated for the last several years, because he falls in between those cracks. He is one of those homeless people. He is one of the people who ends up, I can tell you, he's been in jail and prison more times than he's ever been in a hospital. He is who I fight for, along with so many others. I worked for NAMI. I left a 30-year career to work for the National Alliance on Mental Illness. I'm from San Diego, and I oversaw their education and support programs, and even got to help launch a innovations program under MHSA that placed peers and family members within the treatment community, which was a wonderful augment to services. So I know I can see what works, but I also continue. I still do two. I retired in 2018, kind of. And I still facilitate 2 support groups every month for family members. And I teach the 8-week family to family course for NAMI. I've done it for 20 years now. I'm still hearing the same things that I heard 20 years ago. And but they're younger. At least they're finding help and support now. So I'm glad to hear about the focus on the youth community, the youth and younger people, because we didn't see it coming. My son was 21, already out in the world. He was a medical specialist at Walter Reed. So he is also a veteran. So I always say we end up with another homeless veteran, on the streets. I speak to law enforcement in my county. Those who are dispatched on the crisis intervention calls, and also those in advanced officer training. And I always have a PowerPoint, and I say, this is who my son is, but this is who you're going to meet. I said, you're gonna think that this person doesn't have a supportive family behind them. You don't know the fight. And I always say we receive back the collateral damage of the broken system. It's the families. And there is please look it up, a great report that was done by the National Association of Caregivers called On Pins and Needles, where they finally did a study. It was 1,601, I don't know why that one, families who are those caregivers and what we go through. And we're not even considered. We don't have the support systems of other medical conditions that are chronic. We don't have those systems to say, we need a break. We don't have that. And so we're the ones that sit in the courtrooms. I like right now, my son is in the CARE Act. I had to file a petition on Thanksgiving Eve, actually, as I'm shopping and preparing, because it was my turn for the family dinner. But I'm going down to the court. My brother and sister is sitting there and drove down with me to actually file that petition. But my son still ended up in jail, where he is right now. And so I now, as of 2 weeks ago, before I came up here for my sister's 80th birthday, I went to 2 court hearings. One day it was the CARE Act hearing where my son said he would agree to services. So I am disappointed that it became a voluntary program. That's not what it was supposed to be. And the other court case I had to go to was the criminal hearing, the vandalism charge, the resisting arrest that happens because he's also now re-addicted, on the streets again. So that's how the arrests always happen. And they're not even talking to each other, the public defender for CARE and the public defender for the criminal. There's a lot of changes. Yeah, a lot of things. I'm documenting everything. I'm sending the letters out to the powers that be about some of these gaps that are we're seeing in the CARE Act system. So I have to remain hopeful for my son to hopefully live another 20 years.
Okay.
I always say that my advocacy is why he lived beyond 25 or 30 or 35. And that SB 43 will do what it's supposed to do, and that Prop 1 will do what it's supposed to do. And some of my advocate friends there in that second row, we are trying to make sure our voices are there at the tables that we're normally not invited to, to see that it's done the right way.
Okay, great. It's interesting what you say about the 2 systems not talking to each other. It seems like the fragmentation in California is all over the place.
May I add one comment before we
Sure.
move on?
Mm-hmm.
I think it's really important for people to understand that when the state is expanding, especially conservatorship laws, and purporting to take people into sort of protective custody because they can't provide for food, clothing, and shelter, and that's now changed. Last month, our federal advocacy and protection agency for disabled people in the state released a report that there are 800 people on conservatorships in LA County, sitting in the LA County jail in solitary confinement, mostly people of color, for over a year, at enormous expense to the city, and are also sitting in locked step-down programs that the doctors have said they don't need to be in. And that's the actual situation for folks that are being taken into these forms of protective custody. Mm-hmm. So when the state is saying you can't take care of yourself in various ways and we're going to take care of you, and then they're parking you in solitary confinement with no criminal charges on a conservatorship in the LA County Jail, we have a major civil rights emergency in this state. And that situation and the situation with the jails is not unique. I've worked in jails. My partner is formerly incarcerated. So we're familiar with what's happening to our folks who are supposedly being taken into the state's care in California. And it is a scandal. And I think there is more that is going to come out regarding this.
Yeah.
I guess it's follow-up time. I think it's really frustrating to try to collapse 54 years into 3 minutes. But let me go back to my theme. The problems being described of life experience problems is directly a result of a system of care that doesn't have an idea about what its goal is and how to get there. There are examples out there throughout the whole state of excellent programs that can divert people from conservatorship. My program, Progress Foundation, which is the name of the nonprofit that I'm a part of, main goal is to provide community-based, recovery-based since 1969 and 70, not when it became, a more current and gladly accepted principle, as Dr. Cunnins is saying, based on recovery. We did not decide as a system that people getting better was our goal. So what did we fund? All this money that flowed into the counties was inpatient, medication support, emergency room services, and consultation and education, and some day treatment. Housing was not a part of the lingua franca of mental health until the 1990s. It was considered the purview of the housing departments in the state, not of a vital part of how you maintain in the community if you're living in poverty and struggling with a mental illness and substance use. Vocational services are just verboten in the discussion generally in behavioral health. I expected Prop 63 to generate much more of that, did not do that. There's a profound unmatching of intention with program. And let me just say, I'll follow what Darrell said. Now, this will be what's got to improve. One of them. I've got a list of 20. But let me pick this one. As long as we base our behavioral health system on counties, we will never have a coherent system of care. You realize that if you're having a mental health crisis at the Mexico-San Diego County border, and you get on a bus heading north, depending on what county you get off in, with the same symptoms, the same behavior, the same mental health issues, you will confront a different mental health system as a set of choices for you in each county. If you sleep through LA, God bless you, you're lucky. Because the largest county in this state has what I would say unreservedly the worst behavioral health system in the state for their resources and all of the things they could do. If you get off in San Luis Obispo, you might have a social model alternative to hospitalization that you could get into. If you go north, it's entirely balkanized. And so as long as we have a state that runs its system through the prerogatives of county-based government, we will never have a coherent system. And Darrell, when I first heard him say today for the first time, this idea of a single payer approach may get us in that direction. But we have to have a different framework for agreeing on a set of programs in every community based on size, demographics, everything else that have proven to be effective in reducing hospitalizations, reducing conservatorships, reducing emergency room visits. They're out there. We just have not had a state leadership that pulls that message together and is putting it out as a part of the message. And that's why I'm disappointed in Prop 1. It's a narrow message. It's a conservative message in terms of how it's taking an approach. And it is a repeat, and this was what Jocelyn referred to. We keep making the same mistake over and over. Every decade, we decide we have to have more involuntary care. Because look at all those people flowing into our hospital emergency rooms. Nobody says to that county, and it's not unusual that these more repressive measures come out of LA County. No one asks them, what's your system of care like for voluntary participation? What do you offer people? If it's just a case manager in a hotel room, then you're going to be back on the street. But there is no authority that says we've got to agree on a system of care that is essential in every county that's similar. And that's when we start to build a system that might not go back to the tired old response of let's put them in involuntary care. By the way, providers that say all the time, best practices is what we're trying to do. I defy someone to find, outside of keeping someone safe, but in terms of recovery and treatment, where is there any literature that says forcing someone into treatment results in them getting better? They may be stabilized in a crisis, but their long-term deterioration, their long-term ability to integrate with the community is severely hampered because there's no treatment alternatives in the community.
Great. Well, Dr. Cunnins, I'd love to hear from you about the county. And then, Toby, I would like to hear from you about state leadership after that.
Thanks. I'll make a county to state.
I'm sorry, but I have to say this because Hillary Cunnins is the director of my county. I love the county I work in. But
You don't have to say that, Steve.
no, we've developed programs that are a model in many other states because of how incredible responsive San Francisco has been since 1960. I'm fearing it's getting more conservative now, but counties can be good, but we don't need a system where you have to look for the county that might offer you the services that you'd be willing to take part in.
Thank you, Steve. You didn't have to say that. And it's been going on longer than me. I'll just make a comment about New York compared to California. So New York State has much more centralized control over the behavioral health system than California does. I was a county official in New York. We were 5 counties in New York City. And part of what drew me actually to California and San Francisco was both mental health SF, which I'd like to mention next, as well as the opportunity for more latitude as a county official. And why I am drawn and think it's really important that we work at county and particularly city levels is because a lot of the solutions, in my view, as you've been hearing, don't actually reside solely in the behavioral health department or in the Department of Public Health. It is the interplay of municipal agencies, police, courts, housing, human services, thinking about the challenges are one, again, of, to use my language, social determinants to produce recovery, to prevent involuntary care, is what a lot of us, what I find working hard, challenging, and also opportunistically at the city or county level. But for example, in New York State, there is a single model of assisted, what's called ACT teams, assertive community treatment, that is funded, paid for by Medicaid. There is standards. The state sets the standards. There is, I believe, fairly uniform standards across the state. However, a counterexample is we knew in New York City, we had a wait list for ACT teams of something like, depending on the month, 500 and 1,000. That's ridiculous. So we were interested at the city to open up more ACT teams. This pushed up against the state's global Medicaid cap. We were told at the city, no, you can't expand this. This stresses the state Medicaid budget. We found a workaround because we were another rich jurisdiction to put in local money to open up teams, which we didn't call ACT. We called them something else, which we funded entirely through local dollars. So not an ideal solution. It's not a scalable solution to counties, but that's the kind of role the state, both positive and negative, I think can play. And there's other examples. That's just one. Another thing I just want to touch on, which I feel like has been really an accomplishment in San Francisco that's been afforded to us through Proposition C, which is a local tax that is intended to support development of new housing. And part of that money came into the behavioral health system. Among the things that we have been able to do is build what we have called an Office of Coordinated Care. That office is really oriented to work with people to decrease fragmentation, to increase ability to get people into care and follow them over time, particularly prioritizing folks coming out of hospital, coming out of jail, after experiencing an involuntary hold. We also have built a street team, which we call Best Neighborhoods. It is an example of where we are not fully staffed, but we are been able to stand up teams that have folks there working with in particular neighborhoods who are unhoused, remembering that this money is for people experiencing homelessness, And the idea is to follow them across over time and across location if they particularly hang out in one location or end up in jail, incarcerated, or in hospital, is to really think about them across the continuum so we don't lose them. And so this is going out into community, whether virtually or literally, to create glue to our system for our most folks at risk for the consequences we're hearing now. This is something that historically Medicaid has not paid for, Medi-Cal has not paid for. It is historically not how behavioral health has fully seen itself, with some exceptions like ACT teams, where our responsibility is to go find people, be proactive, and stick with them until they are stabilized into a level of care. It is not it's not a panacea, but it is a kind of body of work which we were beginning to be funded to do in New York City, which we are taking advantage of here, which we hope to continue to improve upon and build, and think about it as both of all layers of prevention, primary prevention, secondary, and on to tertiary.
Yeah.
With all that we've been hearing here, one of the things that I always say when I'm on panels is I think about my son. I just think about him standing right here. My son lives with a condition called anosognosia, which means lack of insight. So my son is not going to voluntarily agree to treatment. He's had opportunities over these 5 years to do both, go both ways. He's had to be involuntarily treated. He's never been angry when he's back to living a quality life, making choices, having independence. But when he is in the midst of his symptoms, he thinks nothing's wrong. So he is never going to voluntarily, except like now, because he's in jail and he wants to get out. So I'm sure that's why he agreed to the care court, was because it wasn't because he thought this is a great program for me. It is because that part of his freedom being taken away. And so it's not always a choice for people. And that is why I stand by when that there are types of temporarily involuntary services that are needed for individuals.
Well, I want to leave time for Q&A, but I do want Toby to give us some insight into kind of what state leadership should look like going forward, and especially if you could talk a bit about accountability and transparency as all these new policies are rolling out. As Neil mentioned earlier, we did a story on No Place Like Home in which voters passed a $2 billion bond in 2018. It was going to yield 20,000 new permanent supportive housing units. And so far, more than 5 years later, it's less than 1,800. So what I want to know is, like, all these policies, all this money, what do you think we need to do?
So, yeah, thanks for the softball pitch, Jocelyn. I think it's important to recognize that and what you're hearing up here, is all true, right? We have profound frustration among families that their loved ones are not being cared for, right? I mean, that's my own family. I've been on the phone calling behavioral health directors, their cell phones in the middle of the night, begging and pleading, right? And, it's also true that we often revert to strategies that are coercive, that are short-term, that give us sort of positive bumps in the short term, but often create profoundly difficult situations in the longer term. The challenge here is that both sides of these conversations can be true, and they are. California made some decisions 30 years ago around the design of our behavioral health system that was intended to capitalize on the strengths of individual communities and counties. There's a reason why, as you know, the esteemed Mr. Fields points out, that you get on a bus depending on where you get off, right? And I spent time with him 20 years ago on that, 24 years ago on that Little Hoover Commission report. But the intent was to create incentives for local governments to recognize areas where, as they make better investments in behavioral health, value accrues to them in terms of their justice costs and their educational outcomes and these other strategies. The goal really was to transfer responsibility and authority using state dollars to actually prop up the ability for counties to go above some statewide floor, right? That the concern was that if you establish a standard, it will become the ceiling, not the floor. And we wanted to create incentives to really tap into the best opportunities. And as a result of that, we can visit every county in California and find something that is working really, really well. The challenge, though, is we don't scale effective programs very well. And so we see this variation because of the reality that we're not accomplishing our goals on housing, on recovery, on employment, on avoiding the child welfare system, on supporting children to thrive in school, K-12 and higher ed. And so, the question here is, how do we save the capacity to capitalize on the creative opportunities, the brilliance of local communities, recognizing that you don't want a system that was born in LA for Siskiyou, right? Because Siskiyou is so differently. And at the same time, create opportunities to continue to raise the floor in terms of the quality and the effectiveness and the impact that we're having. And, there are folks who argue, looking across the world and across the country, that part of the challenge is that we do not have a strong leadership model in California with the elimination of the state's Department of Mental Health. And there is some truth to that. But we also want to recognize that what the state did was really try to integrate health, behavioral health, alcohol and drug treatment programs, right? And not silo through Sacramento behavioral health or mental health separately from these other areas of health and human services, right? We're in a really pretty interesting time. I'm not saying there aren't challenges as laid out by others on this panel. Prop 1 has language in it that elevates the role of the state to provide more technical assistance, stronger outcome and accountability strategies, to do a better job around establishing fiscal sustainable financing strategies, to recognize how we use short-term dollars in ways that aggressively incentivize innovation, that aggressively incentivize the scaling of impacts, right? Yesterday, we were involved in a meeting looking at access to early psychosis services. We have an evidence-based practice established in this country. It's wildly popular around the world. Other countries have said, we will ensure that every resident of our country has access to an evidence-based practice and respond to an early psychosis incident within X days, right? We don't have a goal, we don't have a standard, we don't have a strategy. So, California, because of the Child and Youth Behavioral Health Initiative in particular, the state is really putting time, energy, and expertise into learning, into listening, and into working to support the ability of local agencies to understand best practices, to incentivize their adoption, and to lean in to help. The big question for us, for the commission, I think the big question for the state of California, for the people who live here is, do we move beyond the idea that we change policy and therefore practice will happen sort of on its own? Or do we continue to lean in and learn? And how can we collectively get much more assertive about understanding what we're trying to get done, establishing a goal, really recognizing what drives the failure that we see every day and what drives the success that we're seeing in places like San Francisco and Orange County and Sacramento. Sacramento County, by the way, so that we as a broad state actually get better at this over time. The state of California has a lot of work to do, and Prop 1 lays out that agenda. What the commission has really pushed for, our most important contribution to those conversations, were write it in a way that it can be modified over time, because we're going to get some things wrong, and invest in the capacity to learn along the way, because change doesn't happen overnight. We have to be able to recognize what isn't working, learn from each other, and implement strategies to be successful in Tehama, Trinity, Siskiyou, right, as well as San Francisco, LA, San Diego.
Great. Okay, so I am told that lunch is coming soon, so we only have time for maybe 1 or 2 questions now, but I'm hoping some of the panelists will be available while they're eating their sandwiches. So is there a question out there that, and if you guys are able to answer succinctly, do you want to just... Oh, there are apparently more than one question. Okay, well, you don't have a microphone?
Good morning. Thank you to all the panelists. Fred Seavey, the National Union of Healthcare Workers. Just a question. Jocelyn opened the conversation about systems design, and several panelists have spoken about jails and prisons. And we often hear that the largest site for behavioral health care are jails and prisons. And I think Darrell Steinberg talked a little bit about strategic opportunities. Wouldn't this represent a place for us to invest and make improvements? Are there counties and prison systems that are doing effective things? For example, we hear about Cook County that hired a psychologist as the top official of the board. But anyway, a question.
I would say, I think the goal needs to be that nobody goes to jail or prison because of an unmet mental health need, bottom line, right? That doesn't mean we do not need to ensure improve access to care for folks who are there for, criminal justice involvement that is truly criminal. The challenge we have is it's much easier to get into the criminal justice system than it is to stay out because of a severe and persistent mental illness.
I serve on the Council on Criminal Justice and Behavioral Health the state because my son spent much time in not only the jail, but the prison system. And I can tell you there is programming within both, mental behavioral health programming. And I hate to say that it's helpful when he's in there. I'm just saying that he has an opportunity for care when he's in there, but we don't want them in. And some of the work being done now from the CDR or CDCR is to work with community-based programs. So for reentry, as well as to stop that cycle of coming in and out. So there is work being done, but we don't want them in there. I hope all those clinicians can come out of the jails and prisons and work in the communities.
I'll make one comment too, very briefly. The state's talking out both sides of its mouth on criminalization. I was fighting the construction of a new jail in Santa Clara County, and the county exec came back and shocked everybody and said, we're going to build a 500+ bed maximum security just for mental health consumers. That's happening in counties all over California. And I would just like to point out that criminalization is a choice. There's nothing in our Constitution, there's nothing in our laws that compels the state to prosecute people who are clearly mentally ill, who are incompetent to stand trial, who you can look at for 30 seconds and know that. And some of the most ill people I have ever seen was working in the Santa Clara County Jail's acute psychiatric unit and the acute psychiatric unit of the Sacramento County Jail. So the state is not serious about ceasing criminalization, which it could do tomorrow.
I'm going to take this just a policy mention after these really important comments, and also concur our goal should be preventing every incarceration of somebody with serious mental illness or substance use. 2 things. There are a number of jails and increasingly prisons, including ours, San Francisco County Jail, which has on staff psychiatrists, psychologists, and counselors who do see as part of what they are doing to assess people for behavioral health needs and aim to deliver it during the period of incarceration, and then supporting, and this is in partnership with our sheriff's department, pretrial diversion, many partners trying to work to get people into care. I also want to mention CalAIM in this context. There are enormous policy changes that are going to allow or are allowing counties and I guess states to pay for healthcare services while somebody is in a period of incarceration by not having their Medicaid suspended. This is both now being allowed by the federal government. California has, as part of CalAIM, is implementing that. Additionally, counties are on the hook to provide timely follow-up care to people leaving carceral settings. And we, again, the principle is to avoid incarceration. Just sort of repeat that when in cases of incarceration, there's increasing ability to pay for and then accountability to deliver both care in incarceration and then in the follow-up period.
Jocelyn, thank you. Thank you all so much. We should go twice as long with all these things because there's so many good questions, right? Several pieces of good news. One is that lunch is available right behind us here, which will facilitate our conversation. The second is that I hope nobody's going anywhere. We'll be able to talk and then have Q&A with everybody as we go. Thank you all so much for doing this. Really appreciate you taking the time, and the insights have been great. Thank you so much. And Jocelyn, thank you. We are serving lunch right behind me here. There are some vegan meals that are still on the way, but the rest of the food is already here. The rest of it will be here shortly. We're going to take about 20, 25 minutes for lunch, bring it back here and sit in the beautiful area out there and enjoy the view. We'll start up again, ideally around 12:25, which probably means 12:30, so we keep this going. But enjoy lunch. Thanks.
For those of you who are just joining, I'm Jocelyn Weiner, a mental health reporter with CalMatters. In this afternoon's panel, we're going to talk about youth mental health. We are, as a state and a country, in a moment of great crisis for our kids. Rates of anxiety and depression and self-harm have been building for years. Teen suicide rates have climbed. Children in crisis too often are languishing in emergency rooms for days because all the appropriate pediatric beds are full. But at the same time, we're also at a moment of great and genuine hope. The 4.6 billion, I keep hearing $4.7 billion California Youth Behavioral Health Initiative is being rolled out. Kids no longer need to have a mental health diagnosis in order to get mental health treatment from Medi-Cal. Innovative programs abound, and we will hear some about that today. As in our morning session, I want to try to focus our conversation in the oh-so-simple topic of system change, which you can see we have a lot more than an hour's worth of material to cover, but we will do our best to keep it tight. And we're going to talk about how we translate big promises into widespread change for kids who certainly need it and certainly deserve it. So I want to start out talking about the current mental health challenges facing young people and some of the systemic challenges to getting them the care they need. And then I'm hoping that we can then spend a lot of time talking about what the future looks like and what we can do better. So by the end of the conversation, I hope we can come away with some ideas of concrete steps the state should take to better reach young people. So I hope the panelists will keep that in mind. I'm really thrilled to introduce this amazing panel, and thank you all for making the time today. I will go in order. Alex Briscoe is principal of the California Children's Trust, which is a statewide initiative that seeks to improve child well-being through policy and systems reform. Cassie Poles is a youth mental health advocate who works with the California Children's Trust. Dr. Sohil Sood is director of the state's Children and Youth Behavioral Health Initiative. And Dr. Virgil Moorhead is a psychologist and the executive director of Two Feathers Native American Family Services in Humboldt County. I think you maybe win for the farthest distance travel today. I don't, maybe not. And then Javon Wilkes is the executive director of the California Coalition for Youth, which advocates for youth experiencing homelessness. So panelists, thank you so much for being here. Like I said, we'll try to keep responses somewhat concise since we have so much to cover, and I know clearly the audience is going to have a lot of questions. To start off, I wanted to talk a bit about what some of the challenges facing young people are today. And Cassie, I'm hoping you can kick us off by telling us a little bit about what kids are going through today and what your own experience with needing help for mental health and addiction issues has been like.
Well, good afternoon, everyone. My name is Cassie. I'm 25 and I've been doing this work for about 3 years. So how I got into this is I have a lot of lived experience. When I was 8, I was diagnosed with ADHD. And then when I was 13, 14, I had an eating disorder, anxiety, depression. I was self-harming. And then when I was 19, I got diagnosed with bipolar 2. And then I ended up going to jail and ended up becoming a substance user afterwards. And I was a heroin and meth addict for about a year and a half. And then I cleaned up, got my stuff together, and got into this work and has been doing really well since. So it's been quite a journey. Yeah. So a lot of resilience in doing this work has been incredibly healing to be able to share my story and to encourage other young people to find their voice and to speak up and to build relationships with others. So that way we can all help support each other. And so I had just come back from a conference in Sacramento, and we were having a video chat right before this. And we were talking about some of the struggles that young people go through. And, you know, some of the kids there have to face food insecurity, housing insecurity. You know, I cannot imagine being able to stay at a hotel for a couple of days and then go home and I don't have gas money. I don't have a secure place to live. You know, things that we all take for granted that we have. And, you know, some people have never had to struggle with housing insecurity, so they don't understand not having, you know, the basic necessities just like right at your door. And so it's really sad that, like, I cannot imagine being 16, 17, 18, like even 19-year-old me, like having to go through that. And so already navigating a challenging time plus all that, it's really hard. And I think isolationism is a big struggle. And I think everyone struggled with that since COVID. And I feel like social media also plays a big role in furthering that isolationism. So, and not having enough support, not having enough education, and just not having enough resources in general, I think are a big thing that youth are experiencing today.
Thank you. Thank you for sharing that. Alex, the problems Cassie is describing aren't brand new, though some of them seem to be getting worse. I'm wondering if you can lay out for us some of the challenges that have been brewing for youth over the last 10 to 15 years and what this tells us about where we're at as a society. Briefly.
Yeah, there's a lot to that question. Nothing in Cassie's story about what's going on with young people right now was a discussion of psychopathology. But we are responding at scale in the context of a medical model that has proven ineffective and ineffectual. This stuff that Cassie's talking about is a meaning and purpose and connection, things we don't treat to in the traditional mental health system. And that's what's happening. Young people are growing up with an increasing understanding of 400 years of structural inequality in a culture that equates fame with merit, wealth with value, that tells women they can't be president, that tells Black kids they're not as good as white kids. And when you compare those hard, harsh truths of our culture to self-injury data, it tells the same story. Black kids hurt themselves at twice the rate of white kids. Girls 10 to 14 have seen a 400% increase in suicidality. So the mental health system is absorbing the socially constructed epidemic of despair that children are demonstrating to us. And it happened before COVID. I'm sure you all know the data, right? And COVID poured a bunch of gasoline on it and made it popular to talk about. But the origins of the youth mental health crisis are not psychopathology. They are a social construction. And until we acknowledge that, we can't orient health systems to the true drivers of the youth mental health crisis, or we will inadvertently pathologize young people out of the best of intentions. So I'm not saying things are wrong. 70% of licensed clinicians are white. 80% of kids on Medicaid, over 5 million of them, are kids of color. White people are cool. We're okay. But we know over 50 years of study that cultural congruence matters to health outcomes. So I'm going afield, Jocelyn, but we've made a toxic culture. We now need to teach kids how to survive and thrive in it.
A great summary. Javon, I'm wondering if you can talk a bit about the young people you serve and if they are getting the help that they need, if they tell you what that help is, and then what might be getting in the way of them getting it.
We heard a little bit about the isolation. Young people need to be around people who's going to feed them, who's going to make sure that they have a roof over their head and make sure that they have connection. And right now, there's a lot of young people who are facing housing insecurity, that are on our streets homeless. As an individual with lived experience with homelessness, as a young person, there's a connection that's automatically developed so that we don't have to have that severity of despair that not only the young people feel, but those who care about them and the individuals in this room that care about your community, to want to see young people go from just surviving to actual thriving. And so when it comes to what I see, young people need people to be there. And that's where we need to step up together. And with initiatives that are coming out, we need to maximize on the beauty of young people to where it comes to their lived experience. And as me and Amy talked about, also that lived expertise, because there's something to navigating systems that could add like a different flavor so that we can have a workforce that's culturally concordant, that maximizes on young people who have had that lived experience to be in those positions and those roles to actually support their peers in large ways. So young people are going through it, and they're also going through it together in ways which they're supporting themselves. And if we find ways to maximize on that and actually fund that, that's something that can really impact us doing a better job.
Great, thank you. That I think would be a great segue into Dr. Moorhead, maybe you talking a little bit about the special challenges you face in reaching youth at Two Feathers and some of the obstacles that they have that you have seen in terms of getting them the support they need. And then hopefully a little later we can also talk about what you've done about it.
All right, sounds. Can you hear me? All right. So, I'll say in the, Two Feathers, we serve all Native American youth in Humboldt County, 5-6 hours north of here. And in the last 2 years, the two biggest tribes, one is the biggest tribe in the state of California, the Yurok tribe, have declared states of emergency, crisis for fentanyl, a declaration of at the tribal level, right? At the same time, I've been working at Two Feathers and grew up in the community for the last 6 years. We have a clinical director who was in the county for 10 years before she jumped over to Two Feathers. And over the last couple of years, we haven't seen the amount of suicidal ideation. That at Two Feathers, we work on the ground in the community. We go to where the kids are. And so the suicide ideation, the issues, is intensifying. Now my sample size is 6 years, but I grew up in the area too, right? but I would say that it's the worst that I've ever seen it. And I couldn't agree more with Alex in the sense of the existential despair, struggles as an impact for Native communities. That the in Humboldt County, there's a historian UCLA came and did a book up there, and said that this is the closest thing, because they argue about the definition of genocide. And so he says this by United Nations, this area is genocide, what happened, right? And so that 400 years, or that for us, it's more recent, with the gold rush and stuff. The consequences of that has not led to, as I see it, the medical issues, but it's led to loss of hope, existential isolation, loneliness, lack of resources. Because where the struggle is the most with kids is also where there's the lack of resources and the healthy people to help them, right? Whether it's on the Hoopa Valley Indian Reservation or up there in Klamath, the Yurok. It's really ironic, because where there's the most need is the biggest struggles from a system, talent, all of that, resources. So I think that's the problem.
And I think you see the same thing in Black society as well, with the crack epidemic and mass incarceration as well. Especially as people are just coming out, you have this whole system that's not set up to support them and to sustain them and to welcome them back into society, but also all the trauma that, there's a generation of missing African American men that are in prison, and, kids growing up without their fathers, wives growing up without their husbands, and people don't think about the generational trauma and damage that does.
So, Dr. Sood, you're new to your current role, newish. So I think I'm wondering if you have a fresh perspective on the state's role in addressing these issues, and what's keeping you up at night. Are there structural challenges to getting the money where it needs to go and supporting the kinds of programs that we want to see?
Sure. I joined this fight and the state team because of what I've seen as a pediatrician, because of the decade that I've worked in various different hospitals throughout the Bay Area. And I've seen patients very much like Cassie's story, those with self-harm, those with eating disorders, those with substance abuse issues. I've sent them to the ICU. I will also note I've seen just the remarkable resilience of youth, and how, despite everything that we've just mentioned, they're amazing. They're poignant, case in point right next to me here. They're just so phenomenal. So I'm hoping we can make some differences through the work that's being done, not only through the Children and Youth Behavioral Health Initiative, but through the many different programs that are coming out. To your question about structural challenges, I think you're hearing about many of them already here. What we're trying to do, and I'll highlight two of them. One is trying to really authentically engage with children, youth, and families. And that is a structural challenge. That is different, and that is hard to do. And so through this initiative, we've stood up youth advisory boards, we've stood up youth fellowships to really bring folks to the table, to have the conversations, and to be there as decisions are being made. We are now also working to establish a children, youth, and family network, whereby there's so many folks out there with tremendous lived experience and lived expertise that really should be compensated for their the value that they're bringing and the insights that they're bringing. So can we professionalize the relationship to really respect what's important as we develop these policies? So working through that structural challenge is one that I'd highlight. And the second is we got to break down barriers and silos, right? We talk about students, we talk about plan members, we talk about clients, but really we're talking about children and about individuals. And so as a doctor, I'm learning the language of adult, education nowadays, what local control funding formulas are, what average daily attendance means. And I'm hoping, partners from these other areas are also learning, how we think in the health field and what we consider important and whether that really is important or not, to your point about thinking about really what should our shared goals and shared outcomes be as we go forward.
Now, following up to that, knowing that the CYBHI only has 2 more years of active funding and whatnot, what's going to happen after the program ends? What's going to happen after budget cuts? Are youth in the room going to be a dead thing, and are we going to be forgotten about? And what are the plans to sustain funding afterwards and to sustain these efforts?
Cassie, I was just going to suggest you can take over as moderator. Got my questions.
Yeah, I mean, such an important question, right? I think it's on the minds of many as we go forward here. I mean, maybe I'll just start by saying I'm proud to live in a state that is taking advantage of opportunities to really invest heavily in children, youth, and families. This is a multi-billion-dollar, multi-year investment that I don't know if any of you know otherwise, but in my understanding, there's no other jurisdiction on the planet that's taking this type of approach at this moment in time. And ultimately, I'm here to save lives, but I do hope that if it is implemented effectively, and if we go forward in that way, we're actually also saving money to the point of trying to think through how we can sustain some of these programs. Because if we keep kids out of hospitals, right, if we keep kids out of emergency rooms, if we keep them in school, if we keep them away from substances like fentanyl, they hopefully stay alive longer and live fuller lives and are more productive in many different respects, however you define that. So I'm hoping we can think really creatively and comprehensively about funding as we go forward. And then to the specific programs, there's more nuanced considerations that happy to go into now or at another point in the conversation as well. But we certainly need to figure out a lot as we go forward.
Sure. Why don't you talk a little bit about the California Youth Behavioral Health Initiative? And I mean, I am curious about its limitations and what makes these efforts sustainable. If different leadership comes in, or how do we kind of bake it into how our state runs?
Lots of questions in there. So I'll start with what it is, and then we can talk about some of the other pieces there. So, as I mentioned, it's a 5-year initiative. We're on year 3, to your point, of the rollout, although the end date kind of depends on different activities have a different end date overall. And it is trying to transform the way that we support children, youth, and families throughout the state. And part of that is reimagining what a behavioral health service and a support actually is, and really transforming that ecosystem. And the strategy behind it isn't, too, I don't know what the word is. It's not rocket science. It's ask children, youth, and families what they need, and then build services with them, not for them. And, as we've done that, this is what we've learned. Certainly, we need to do better in the healthcare setting. We need more psychiatrists, more social workers, a bigger workforce. I think that was brought up earlier in the panel. But we need services. We don't play out our lives in the doctor's office, right? This is homes. This is communities. This is schools. This is online as well. That's where we live our lives. And what young people and families have told us throughout this experience is don't just focus on the crisis at the tip of the iceberg. Focus on that, but focus at what's happening underneath as well. So be prevention oriented, be youth centered, be equity focused, to very much the points that were brought up as well. And what that's led to is a series of investments and activities, more than 20 different work streams that are expanding home supports in many different respects. I'm talking about, more parenting programs, services that take care of the parent and the child when they're in the doctor's office, a number of different programs in the community, youth centers, places where people can have outlets where they feel like they're connected to their community in different respects. A lot of work being done in schools to ensure that everybody really learns some of the skills to take care of themselves, to ensure that in a school setting, that the staff, the educators, everybody there really works to create a culture of belonging through staff training programs and other pieces, and to deliver care services on or near school campuses. Because My kids are there right now, right? 6, 8 hours a day, most kids are there. So if we can find a way to integrate services in that setting, it can make a big difference overall.
Now, have you guys thought about partnering up with different branches within the government to try and like lower costs? Like, for example, with the workforce issue, partnering up with the education system and maybe putting incentives out there to get more people of Black, Brown, and other cultures to become providers. Like, has that ever come up in conversations?
Yeah, super important question. And others can feel free to chime in from your experiences as well. But what we've heard, and you tell me if you feel otherwise, is that young people want a workforce that looks like them, comes from their communities, speaks their language, and generally speaking is sometimes younger too.
Yes, young people want to work with young people, and that's something that I've heard over and over and over. And right now I've been looking for employment, and so I can see that some employers are trying to implement that, but I think because this is still so new, it's really hard to get young people who have the experience that companies feel are ready to take positions like that.
Yeah, and because of many of those issues, we are standing up a brand new profession in the state. It's called a certified wellness coach. I think if you want to learn more about it, you can go to cawellnesscoach.org. But essentially, one of the issues that we've noticed is that for those who are interested in behavioral health work, there's kind of long-term career options for you. You can get a master's degree, you can get a doctorate degree, you can become a pediatrician, a psychiatrist, a psychologist, right? Many other fields. But early in the career, there's actually not many options out there. So this is meant to actually fill that gap and to have folks from their communities have an entry-level specialist position where they can be gainfully employed in not just in the healthcare setting, but in schools, in community centers, in many different spaces to be able to engage with young people as wellness coaches.
And
go on. Sorry, I think this would be a great moment for Dr. Moorhead to tell us about his program, because it seems like with the pods, that's a lot of what you're doing.
If I can just say that the Wellness Coach program was inspired by programs from tribal communities in Alaska in particular. But just want to mention that highlight.
When I was going through grad school and stuff, I would talk to some of the elders and stuff, and they would say, especially when I was working at the Native American Health Center, there's Oakland, they say, you got to think 7 generations. So with that, there's teachings in indigenous tribal communities to think 7 generations, which is 7 generations forward, 7 generations back. That's our way of doing things in many tribal communities. And so to answer your question of building the workforce, to building the healing, not just healing, but also the empowerment, the development of people. And so at Two Feathers, we have, I was in the Bay Area and we were a staff of like 4 about 5-6 years ago. Now we're, a staff of 45. And we've continued to figure out, take one step forward of how to meet community need, how to meet the youth and families where they're at. And part of what we found is that development of folks and giving them opportunities. And so one of our programs that we started in right around COVID, because so much of what we believe is you got to be around kids to be able to impact them. And you have to meet them where they're at, and you have to stay in relationships with them. Because like I said before, we're trying to heal multiple generations, sometimes 7 generations. So to think that we're going to pop a pill or we're going to do a 6-week counseling group is going to heal some of the struggles, no. So this work pod that started, we'll call it work pod, which is youth employment. We started post-COVID because we couldn't reach the kids. It was hard with COVID. So we had to be creative. We're like, well, why don't we just pay them? Especially with the teenagers, right? And so we've grown the program from of like 2 to now I think we're at 55. And we're trying to integrate them into all of our other programs, our mental health counseling, our cultural-based programming, and really what we're trying to do is the positive youth development. Is like I say to some of them, it's like you come here, and this, I'm a psychologist, licensed psychologist. I reduce your anxiety, or I help you don't feel depressed. But if you're still beating up your girlfriend, that's not good for our community. We have to think in that way. There can't be a separation of, I'm going to fix your anxiety and depression, and you need to be a good community member. That's deeply involved in embedded into our episteme, our ways of knowing, is being a good community member. So this work pod, these ambassadors that we've grown, is that sort of thinking. Many of them are in mental health counseling too, that sort of integrated model. And then I think the last thing I'll say about since I have a chance, with the community, the wellness coaches, is how do we, because there's criteria, such as you got to have, I believe, correct me if I'm wrong, you have to have certain credential. You have to have AA in social work, in child development. Well, that's a big barrier for our community. So I was really excited about the wellness coach. I was like, yeah, let's get, because, that's how we connect and build trust within the community. But we have to really think and get really deep within the community to understand somebody said earlier about implementation. Well, that's going to be a big barrier in implementation. And on the Hoopa Valley Indian Reservation, where we do a lot of our work, I can tell you that. Yeah.
Can I add to this real quick? And I think in adding to that, and it's also hard to get younger people in this position, because I think long-term recovery and stability, especially with having severe mental health issues. And so I think if jobs had more support in that, whether it's offering a work psychologist or having really good insurance benefits, I think is also another good way to be able to get young people to start, but also to help sustain their career path and not go back into old habits, because this is something that it can take a lot out of you, because you don't see the best in society every day. And especially because people who are in this work are very empathetic of other people. And so, it does wear on you. And that was something we were talking about earlier, like how to be able to do this job and not take everything home with you. And that's a skill set that I think a lot of youth aren't given, and that needs to be part of the work culture to continue to support them.
Did you want to? If you were looking.
I guess you was reading my mind. Okay. When I think about the workforce, right, the California Coalition for Youth, like, we're always thinking about how do we empower young people to be in these positions. And right now, with what is at the state level, right, we know that there's barriers that's going to be bumped into. But it's beautiful to see more investments in youth advisory boards, the schools. I mean, here in San Francisco, you got organizations that are putting up beds to house young people in our schools. We got over 250,000 children that are experiencing homelessness with their family. Over 12,000 young people that are unaccompanied experiencing homelessness. And those include parenting young people, right? And with the statistic of a young person experiencing homelessness increases because they experience homelessness as a child, goes up by 40%, we know we got to do better. So when I think about workforce and I think about the generations that are stepping up and stepping in and being able to take advantage of, becoming a peer support specialist, taking advantage of what the state has unveiled to make sure that, hey, let's maximize on workforce investment dollars. Let's maximize on the, doula opportunities, the behavioral health coach, but then also, within my organization and our members, AB 222, that was the Golden State Opportunity Program, where you have scholarships for individuals who have that lived experience to not just get funding like Title IV-E funding, but then go right into, instead of the county, go right into our nonprofits that are boots on the ground doing this work, but maximizing on those scholarships, letting folks know this is available so they can get that AA, so they can get all the things that are necessary so we can build out that culturally concordant workforce with young people. Because guess what, when you're thinking about generations forward 7 years, generations back 7 years, I'm thinking about the young people taking care of me right now. And so the question is, how do I want them to show up? And if they don't have housing, how do we make that happen? We're working on legislation like, SB 1079, where if we're talking about housing bonds, we need to talk about youth being a part of that conversation. When we're talking about behavioral health in the future, we need to have youth at the table, actually in position to make sure that their voice is not just heard, but it has an impact and an influence on what is to come for the next 7 generations. And big proponent of workforce. That's what got me to being an executive director, where I'm not just an executive director, I'm also a mentor, a father, a community member of California, born and raised, roots. And to see my city, to see my community, to see my California have to struggle when it comes to supporting our youth, I think about the genocide of our children. That's a generation. I'm not going to stand by and just walk. I'm going to run and fight so that our young people, our generations to come, have a fighting chance, and hopefully the best thriving chance to also be my caregiver if need be.
So, because kids shouldn't be hurting and, hurt people hurt. Like, kids shouldn't be hurting at the end of the day. Childhood is supposed to represent innocence, and that innocence shouldn't have to be taken away because there's not someone there to stand up for them.
So thank you all for these amazing comments. Alex, I would love if you would talk a little bit about how we're hearing so much urgency and so many best practices. How do we translate the desire to do better at the state level and the investments into taking these kinds of things and spreading them everywhere? Yeah.
Well, we definitely have a last mile problem in California. There are 4 new provider types in Medicaid that have been created in the last 2 years. SB 803, certified peer specialists, community health workers, wellness coaches, and doulas, all 4. So there are 4 new ways you can get paid without a traditional license to help folk who look like you. And our stated goal as a state was between 20 and 25,000 new providers. And I'll leave it at it's not going well. So we've created an incredible opportunity. But our implementation science, I think the clinical term is kind of sucks. So that's nobody's fault. Like, systems change of this size and scope is not easy. We're trying to integrate folk into clinical settings who practice differently and think differently and look differently. So no, I'm not suggesting like, oh, we should have done it. But that's a major issue, is we've created the opportunity, we haven't created the practice. On the Youth Behavioral Health Initiative, I just have to say, there are things in it that we could all quibble with up and down and left and right. There are 2 massive things that will exist beyond its life that have to be named and honored, that are literally groundbreaking. The first is we made schools automatically in network for all managed care plans. Like, if you guys aren't tracking that, it's the biggest policy change in the history of youth mental health. Like, it plays on the portability obligation of managed care plans. Like, when you go travel to Glacier National Park, and if you get in a car wreck, that ED treats you and your health plan has to pay for it. Well, basically, we said all schools are so important that any service delivered in school has to be paid by your managed care plan. And it's not just Medicaid, it's also commercial. Like, it's literally groundbreaking. Like, no one's ever, and we got it in law. It launched in January. It's going to hit 1,600 school districts. By the way, it's going to also suck because it's hard and difficult, and it's just difficult, but it's incredibly huge, and it lives well beyond the CYBHI. And the second one I just want to highlight that is so essential is this thing called the dyadic benefit. And basically what they call the dyadic, DYADIC. And what I will just, the paper that launched it was called Babies Don't Go to the Doctors by Themselves. So you don't even have to read the paper, okay? Basically, low-income people interact with the healthcare system the most frequently in the first 3 years of their child's life. Just like you took your kids, you go to the doctor 12 times, but the caregiver is invisible to the healthcare system because Medicaid pays by identified patient and diagnosis. The kid's the patient, and no one's diagnosing a 0 to 3-year-old with nothing. So mama or caregiver doesn't exist. And the state of California courageously created a benefit for caregiver to get mental health on the kid's ID. Why the kid's in the room? It's the first time any state has ever created a benefit for a patient already in the room. Like the implications of how you could impact millions of children will exist well beyond the Youth Behavioral Health Initiative. So there's some pieces of the Behavioral Health Initiative that were largely like throw money at stuff. We can critique those if you want, but there was also a really thoughtful approach to some systems changes that will live beyond it.
I'd also like to say, when Alex was mentioning the 4 new provider classes, community health workers was a part of that. We just had our Youth Empowerment Summit, had youth come from all over California with lived experience with homelessness, disconnection, and instability. And we had someone on site who was sharing that you can earn, learn, and grow within that profession, meaning they can get up to over $2,000 to learn about what it takes to be within that position. And then you throw in the other services and opportunities that are available when it comes to workforce for young people, especially when it comes to opportunity youth with at the federal level. They are expanding that and making sure that we focus on our most vulnerable youth. That piece right there are making sure that we're putting this in front of the faces of young people, because again, they're tired of seeing the suffering, and they are also so empowered to do something about it. So their interest even goes further to be able to be at our schools, because if they are in proximity to their peers, to the next generation, they can be within those schools to make things tangible and happen and keep those relationships that are important going.
So I have like 100 questions that I know I can't answer, can't ask, because then I won't let anyone else ask questions. But I was wondering if, since after this we're going to have a Q&A, and then we're going to have like an audience time for everyone to talk, I was wondering if maybe we could at this point wrap up with one final thought from each person. Just briefly, if you could say one concrete change, one piece of legislation, one thing that you think that we in California could do that would help us serve more children and serve them better, like it doesn't need to be long, just a sentence or two, what would that be? And then I'll open it up for the audience to ask questions. Do you want to, whoever wants to start can start.
I think substance use, harm reduction and prevention, and just services in general, we don't have enough for it. And I think also kids with mental health or chronic conditions, I think insurance should have to extend past 30 when you're on your parents' insurance. If those are 2 things I could change, that would be it. And I think above all, in this conversation, to take away from it is that we need love, kindness, compassion, and outreach before money, before agendas, and connecting with youth to be on the ground to understand truly why we do this work, and not just seeing everything as numbers and not seeing the human side of things, because that's where we start to turn our brain off.
We're only allowed to pick one.
Well, Cassie did 3, so I guess you can do.
So I actually think the reform landscape is pretty narrow when you get to kids. I know we're talking really broadly and we've said things, but like it's schools, primary care, workforce, and access criteria. Like, and we've already knocked down the access criteria. Like you don't have to have a diagnosis anymore. So workforce, schools, and primary care. And I know there's tons of other things to do, but like, I think we need to be a little bit more like a laser beam and less like a fluorescent light bulb. Like focused investment in direct and specific startup funds. Like we don't come out of our mamas fully formed. You don't show up where you're doing work revenue neutral. It takes 12 to 18 months when you start doing mental health work before you even know how to bill. And so we've created these opportunities. We haven't created the commensurate investment to roll them out. So I would suggest narrowed but significant investment in growing the number of people in the four provider classes so that they can actually be working credentialed and getting paid. Growing the investment in the adoption of the dyadic benefit, and growing investment and specifically in the role of schools and the opportunity to provide services there. That was my three, just like Cassie.
I already said SB 1079, where it comes to making sure that the conversation is lifted when it comes to housing for young people. And I would say ditto to what Cassie said. We need to love on one another. We need to be a part of each other's team, and we need to prioritize the next generations to come. You heard it here loud and clear, 7 years back, 7 years forward. I'm looking around the room. We gonna need young people to show up in their most vibrant and beautiful selves, and so we can help them get there.
I'm gonna continue on that love theme. I think I'm a pediatrician. I'm a dad. I'm directing this children and youth behavioral health initiative. So I'm all about the kids. But when you talk to them, they also say you grown-ups have to look in the mirror a little bit, and you have to take care of yourselves. You have to take care of each other. You have to take care of this planet. And I think we have to keep all of that in mind as we go forward. It's very much about how we create the world that then our youth inherit, and the messes that they have to deal with. They're born out of all of us. So the more we can focus on some of those issues, I think that's equally important to this conversation.
I'll say, one thing, I moved from the reservation and I was gone for 17 years, and then I came back and I started working in the mental health, social service, child welfare. I'm like, man, why does it have to be so depressing? There's a lot of suffering, social suffering. There's a lot of pain, but the systems and the people, and it doesn't have to be that way. It can be vibrant. It can be fun. It can be engaging. And so we need more early intervention, prevention, cultural-based kind of programming, because, one of the biggest barriers too recently since COVID and prior to COVID is staff burnout and turnover. And so how do we create systems that are vibrant, that are thriving, that are fun? Well, that's early intervention, prevention, cultural-based programming, so that we have those kind of organizations and systems where more people want to work in. And I mean, you think about a kid, if he's going to come, or she or they are going to come, oh, wow, that's cool. That's fun. Let's do that. And then you get them into the mental health counseling. So I would say that sort of funding.
Put toys in your office, and I guarantee your therapy sessions will go a lot better.
Okay, I think we have more time this time for some Q&A. So does anyone have questions? And is there a mic person?
Hi, my name is Mayra. I'm with Immigrants Rising. We work with the undocumented population, and I'm loving all these conversations. But one of the things that I took a lot of notes, and something that I want to highlight is, Alex, you said cultural congruence matters in outcomes. And I heard a lot of you mentioning that. And so just want to highlight that, again, when you go with someone, with a mental health provider or any type of person that's taking care of you, you want to see someone that speaks like you, that looks like you, and so on and so forth. Undocumented folks, they can become mental health providers, but after they graduate, as you know, they have to accumulate 3,000 hours. We have to volunteer them. There's no payment for undocumented folks to get licensed. After graduation, till we become licensed. And I say we, because I am formerly undocumented. I also hear you saying we want young people out there. I was able to start grad school until I was 30. I'm going to turn 37, and I just turned in my 3,000 hours last week because of this huge barrier. And to my knowledge, there is no other fully undocumented folk in California, not a fully licensed clinician that is fully undocumented in California. So this is also something that what can we do about this? Other states are able to, associate clinicians are able to become independent contractors, which this is something that in California, undocumented folks can become undocumented contractors. But then we have that barrier because of AB5 of, well, you can't. So you gotta volunteer those hours. It took me 4 years to volunteer part-time. Those 3,000 hours, well, I was doing independent contracting work part-time. And I know quite a few folks that are doing this. So with Immigrants Rising, I was able to co-create a program where we provide a stipend to those folks that are accumulating those hours so that they don't have to volunteer all of them like I did. But it's still not enough.
Dr. Sood, do you have any
Just
thoughts
putting it
on
out
that?
there.
Yeah, I mean, you don't have to if you don't, but that you would maybe be the natural person.
Sure. I'll just say I very much appreciate the comment. I think as Jocelyn is giving me some grace here, I've been on the job for a few months, but these are the types of issues I want to unpack and I want to understand a little bit more. So maybe we can talk a little bit more afterward and I can connect you to folks to learn more. That's great. Please.
Yeah, and I do know Susanna's here from the Kaiser world who's been looking at these issues, so you should definitely connect. Okay. And I also I know that, well, I want to say two things. First of all, California, as of January 1st, closed the coverage gap. I'm very proud to live in a state that does not discriminate for access to healthcare based on immigration status. So remember, we added the 21 to 50s.
January 1st, 2024, before undocumented folks could not get 28 to 54, could not get access
Correct.
to healthcare.
Right. 2015, we added kids, SB 75. Then we did the young adult expansion. Then we did the older adult expansion. And we just January 1 closed the gap. So just want to say on that side, it's very proud to live in California. But I also know that Kim Lewis at the National Health Employment Law Project is very much interested. Susanna is just connected to her in this issue. And she's exploring a potential solution to this, which the state may be able to help facilitate. So if you two connect, I think you'll get some good information. And thank you for persisting through that journey.
Hi, I'm Dale Milpay. I'm with the Northern California Commission on Psychiatric Resources and a member of the California Advocates and FASME. I have a question about your, behavioral health counselors that are going to be going into the schools. Are they, and how will they be trained to recognize the onset of schizophrenia, which often happens at the end of high school? And what are they going to be prepared to do if they notice signs of psychosis in children?
Yeah, and thank you for that important question. And I think a lot of work needs to be done on many different types of psychiatric conditions, including schizophrenia. More resources and policies need to certainly be built. This wellness coach workforce, as I was mentioning before, is a little bit earlier in their career, right? So they are not licensed providers. They are trained providers, certainly, and professionals, but will be practicing and working in many different settings, including schools, under the supervision of other types of provider classes as well. And so you can think of them as really focused on screening services, on prevention-oriented services, but should they find things that are outside of their scope, that are concerning in any particular way, part of the training, part of the understanding of their qualifications is to work up that chain and to raise a flag and to move forward there.
There's no place up from that chain currently if somebody is in.
Well, let's just be super clear about, in order to bill Medicaid, you have to be a licensed practitioner of the healing arts. None of these 4 new provider types work independently. They must work under the direct supervision of a licensed practitioner of the healing arts. So they're not just going to be out alone in the universe conducting like med assessments or like it's really important. Like they are the same way when you go to a doctor's office. Like the doctor's running the show and you may talk to the doctor, but they don't take their weight. They don't take your weight. They don't do the paperwork when you sign in. Like, we know that doctors are a precious resource. And so we put them on teams and they work at the top of their license. Behavioral health is like 50 years behind. We give every kid a 50-minute psychotherapy session. What the actual, right? Like, why not? I say, yo, what's up? How you doing, buddy? Like, maybe you don't need to talk to a therapist every time you interact with a professional. So these provider types are an attempt to do delivery system reform, but don't get too freaked out. They're not going to be out there doing psychotherapy or med assessments.
I'd also like to add that one, thank you, Maida, for also trailblazing as well. Sound like you were making sure that folks who, even though you had to go through what you went through, but that those who follow you get the opportunity to be lifted up even faster. Okay? Dale, life preservers. That's what that is. We have people who stand in the gap, and when they're able to build, when they're able to have that supervision and move up, those are where it's crucial to have life preservers, individuals who will stand in the gap and help that young person survive to the next day, even if the services aren't there the next day, to the next day, and keep it going forward. But as you also heard from folks from the panel, we are also taking into consideration the importance of making sure that the soul is okay and finding ways to make it fun. And young people can bring that again to that culturally concordant workforce to be able to fill the gap as they already have been, but putting them more in position to take care of themselves with occupations that fill a role and move them towards having the licenses that they need. But of course, making sure that some payment is put in place.
Yeah. Johanna Furman, and first of all, thank you for this panel and the luminous work that you've been doing on this initiative. I think some of the changes that you're talking about are groundbreaking, clearly. $4 billion is a lot of money to be infusing into an already existing system, fragmented though it is. And I think, getting back to what Cassie had said at the very beginning, what's going to happen? What's going to happen? And so my question is twofold. What is the structure that you have in place now to enact the changes in these remaining 2 years? And what thought is being given to modifying the base of your services? Because we spend a Godzilla amount of dollars out there in our public systems and commercial as well, on existing systems that are not working very well. And here you're coming in with some wonderful innovations. So what is the commitment to make changes once, and are you getting the data, not to dehumanize this, but in terms of really making the case at the state level that there need to be changes at the end of the initiative?
Yeah. Thank you for those questions. Yeah. Assume it's directed at me, right? Unless anyone else wants to take it. Yeah. So in terms of the structures that are in place for implementation, this work is being done through many different aspects of state government and the California Health and Human Services Agency in particular. So they may be players that those of you who've been working in state government or understand state government for a while already are aware of. Like, for example, the workforce work is happening through the Workforce Department, which is the Department of Healthcare Access and Information. A lot of the payment reform and restructuring is happening through the Department of Healthcare Services and the team over there. I did mention a number of very large communication campaigns that are happening. If you have your phones, you can go to neverabother.org right now. This is a youth suicide prevention campaign that just launched a few weeks ago, being led by the Department of Public Health and the Office of Suicide Prevention there. So it is housed within various entities of state government, and ideally, imperfectly, but with community really at the table and in those conversations as much as possible. Now, to your specific questions about sustainability and where the pieces go, that I think we have to take at almost a activity by activity level. So I'll just highlight a few examples and we can go from there. And Alex, brought up a number of the ways that some of the payment reform and coverage pieces really are designed such that they are in perpetuity, right? They can really make changes so long as we actually get the providers out there and the services out there. So a lot of these investments in those areas are catalytic in some degree, right? They are infusions that raise awareness that, for example, the wellness coach workforce, we have to work with colleges to have them understand this new type of training that's necessary. We have to build awareness of it. We have to work to create funding sources for employers to be able to bring these folks in as a starting point. I think you brought up a lot of the issues that change is hard and change takes time, and laser focused initiatives that create that infusion are important at the start, but if done well and right, don't require that same degree of ongoing robust investment. Of course, they require investment going forward, but think of this initiative as a catalytic, massive infusion to kickstart, to get us all reoriented a bit, and then to kickstart the work so that it can go forward in a more sustainable and incremental manner thereafter.
Who do you have working on these areas? That's really my question. At a structural level, at a resourcing level, the state has enacted this. What resources do you have that you're able to direct and manage to make those investments, even with an understanding that over time they will titrate down? They won't be needed.
So in terms of the resources and the approach, and we can maybe continue the conversation if I'm not answering it correctly, 5 different departments of the state are working on this. Office of the California Surgeon General, Department of Healthcare Access and Information, many, many others, and teams within that. So we're talking, I would say, I don't know, maybe hundreds of state workers are focused on this initiative, and then combine that with hundreds of community partners and organizations that are involved to some degree, and then expand that further, right, to their networks and others. So it's hard to say to that degree of granularity who's involved, because ideally and hopefully in different aspects and different work streams, so many of us are involved. And I actually hope all of you in this room engage with it in one degree or another, in sharing the messages and engaging with the campaigns and lifting up the workforce and sharing information about it. Okay.
Are we moving to the open floor? Okay. So one last question, and then we're trying to leave a little time for open floor discussion where people can just generally share their thoughts. So I don't know where the microphone. Oh, there.
Hi, this is for Dr. Sood too. There is one more promising RFP or component of the CYBHI, and that has to do with community-defined evidence practices, which is what Virgil was describing, these very positive cultural-based programs. We're waiting for that to come out, and we haven't heard anything definite. Do you know if it really is coming out and when?
So it's still certainly part of the plan. I think for context for everybody, the Department of Healthcare Services announced basically 6 rounds of funding that in total equaled, I think, more than $400 million of funding to scale up different practices that are existing in the community. And a number of rounds were defined as evidence-based practices. So those for which there's a robust degree of literature that suggests we really need to do more of these types of things. Positive parenting programs is one example, many others out there. And then another round that you're referring to called community-defined evidence practices, which are so important as well. I just want to start by underscoring that. Some of those types of practices were included in some of the prior rounds of funding that have gone out, and conversations are ongoing about the logistics and operations of the forthcoming rounds. So. I'm sorry, I don't have additional details around timing at this point in time, but I can get back to you.
So I think now we have a few minutes before we close and just wanted to give everyone here who wants to say something about kind of where they see, you can probably also squeeze in a question, but we are trying to, just open it up so that there can be a little bit of conversation around some of the things that have come up before we close.
Let me real quick just first thank everybody on the panel for doing this, for taking the time, for being here. Such an important conversation and traveling long ways in some cases to get here. We appreciate that. And feel free to just stay here or make yourself comfortable in the audience, whatever you like. We thought, because there's so many people in the room who are engaged, who are professionals, who are parents, who are family members, who, for whatever reason, policymakers are engaged in this conversation. We want to give you a chance, and some of you had a little bit in the question time, but give you a chance to share your thoughts and have a little bit of a conversation here about where we go next, right? Where do we go from here? How do we take this conversation forward in our journalism, right, as we cover this and all of your work in the industry? And we'll start here.
Thank you so much. Thank you all for your panel presentation. One thing that's occurring to me is the fact that, like the morning panel, that issue of the workplace and the workforce shortage is so crucial. I am on the board of NIMI San Francisco, and we train peer specialists to work with families, to work with people living with a mental health condition. They come from the communities they work with. We have a class for parents of young children with a mental health diagnosis. So what's coming up for me is, even we have this short-term acute crisis. How can community organizations do more work collaborating with the state to help to fill that gap? Are there ways that we could be doing more? Because we need it right now. We can't wait for the bill to help people get a more advanced degree comes into fruition. We need it now. So I'm just curious what your thoughts are about how, you mentioned that program wasn't so successful. What could help?
Well, go ahead, Cassie.
I think, actually, you go ahead. I'm going to formulate my thoughts.
So some of the 4 new provider types, CHWs are live now. You can get a CHW certification with 40 hours of training from the Urban Peace Movement and bill $26 of CPT code. So in the very, very short term, there's a way to pursue CHW, doula. The wellness coach isn't live yet. So we're still talking speculative there. And that will be difficult and time consuming. So it's not actually imminent. The SB 803 peer certification is live, but we skipped a truth in our conversation today that I have to name, which is the state of California has made a decision about the future of mental health. And it has narrowed the role of counties and dramatically expanded the role of managed care plans. Okay, I'm going to say this one again, because if you don't see this, you're missing. And we could literally argue all day long, up and down, left to right, if you agree with that or don't agree with that. But it done been happened. It's happened. The decision has done been made. Prop 1 was a further narrowing of the county. So remember, we have this public mental health system, your county mental health plans, the historic mental health system. The only game in town until 2015. But then in 2015, in order to comply with the Affordable Care Act, we added a mental health benefit to the managed care plan. And I'm not speaking, this is Alex, not the state or anybody like that, right? But there's been historic tension between the counties and the state, between the county mental health plan and the state, lots of bad blood. And in most of the reforms of this system, they're being run through the managed care plans, not through the counties. So it's just got to be named. Of those 4 provider types, doulas, CHWs, wellness coaches, all paid by the managed care plan. Only SB 803 paid for the county mental health plan. So don't get it twisted. If you want to do a lot more in mental health, you got to have to figure out how to partner with managed care plans. And every county has a different economy of managed care plans. Each one is different, and you got to learn it. The good news is half of the plans in the state are public plans. San Francisco Health Plan. Publicly accountable, created by the Board of Supervisors. It's a whole new world for advocates like NAMI. And when I go to those meetings, there ain't nobody there but me. So learn about the opportunities to impact the behavior of those public mental health plans, public plans, because they are yours. They were created by your Board of Supervisors and should be accountable to you.
Go to the meetings, right?
Yeah. And I think for the youth workforce, for example, I think right now, until there are more structural changes and more money and et cetera, I think just youth having to be determined and finding the right people to mentor them, to help them get education and to help with the workplace shortage, I think is just taking a lot of determination from youth and just having the cultivating culture to help along until we get to a better solution.
I would also just add, potentially in healthcare settings, but certainly in schools, a lot of people are actually already doing the work that wellness coaches would be doing. And part of the reason to categorize this group of people is so that they can get paid, right? So that we can find a way to sustain the work going forward. So as we go forward, I would say look within your own workforce now and see if there are folks who already meet the different pathways toward certification, such that you can get ready for some of those changes to come.
Thanks. Other thoughts on where we go from here? Or things that we haven't talked about today that should have been brought up? Around to you.
Hi, Teresa Pasquini. I am a recovering angry mom and proud mom of an adult son who lives heroically with schizophrenia, diagnosed in his early teens, has been conserved for the last 22 years by the state of California and fallen through every jagged edge of every broken piece of our system. And so I'm here today. I'm a NAMI member. I am former mental health commissioner. I'm so inspired by the conversation here, and obviously in the earlier conversation. But to answer the question, what can we do? We can start respecting families like mine, and we can stop blaming us. I think families are the F word in the mental health system. I don't think we are appreciated. I think we have lived expertise as well. I think, and I think that's part of the culture change that has to happen. We are the unfunded mandate in the system. We are the caregivers. We're the nurses. We're the teachers and the drivers and the ones trying to navigate before we ever get to any of the institutions in the formal institutions. And so I hope I'm also proud, founder of a behavioral healthcare partnership at Contra Costa Regional Medical Center. Contra Costa also has its own health plan. Contra Costa has its doulas and its community health workers and whatnot. And so I've been studying this for a long time. And what I don't want to see happen is I don't want to see sons like mine continue to be, allowed to drop off the cliff and fall off the cliff. Some people need care all along the continuum. And so I don't want to think that if we just start providing school-based services, that we're going to somehow cure anosognosia and that, if we don't start marrying the medical model with the recovery model for some people, then we're going to leave a lot of people out. And so I greatly appreciate this conversation, but I think reform has to really bring families like ours in. So thank you.
I 100% agree with that. I think families are really important and they get forgotten about. And, just being the daughter of, having to deal with having chronic mental health issues and having them for the rest of my life, I understand how some people can fall through the cracks. Like I've been lucky to have my parents and to have private insurance. But I know because I'm about to turn 26, I get to deal with that, nightmare that, not looking forward to it,
I had to drop my sons at 26. Yeah. And so I think Jocelyn wrote an article about that that was mentioned in it. So I'm so impressed and you're so inspiring. And so thankful that your family was there for you. And thank you for being here and being such an amazing speaker.
Thank you. I appreciate it.
I would, so I'm a practicing pediatrician, and a few weeks ago I took care of a child who I diagnosed with diabetes, and he was quite sick, and so we sent him to the ICU. And I told that family, you know, as you're going there, you're going to be there for a little bit, but then you're going to leave that ICU and you're going to stay in the hospital for a little bit longer, so you, the child, and the family understand this new diagnosis, right? So you learn how to count carbs, you learn how to administer insulin. This is life changing, right? This is a big difference. We don't do that for psychiatric illnesses as much as we should. And you know, I'm proud that as part of this initiative, one of the programs that has been scaled, announcements were just made a few weeks ago from the Department of Healthcare Services, was scaling coordinated specialty care for first episodes of psychosis. So that programs like this, where you coordinate, you talk to the family, you talk to all the different providers, you figure out what's the game plan now going forward, and let's all get on that page early on in the illness, can hopefully make a difference as we go forward there.
It makes a big difference. Like for me, always having like a psychiatrist, a psychologist, an addiction therapist, an addiction med doctor, a regular doctor, like that was definitely key in being able to sustain care. Like I've had one bipolar like episode in the 5-6 years I've been diagnosed, and that's, you know, pretty incredible, just because I have such a good care team and they work together to make sure that they're providing the best for me and working with me to make sure that our goals align.
Wow. Other thoughts to share as we wind down here? Yes.
Hi, I'm Jasmine. I'm with San Francisco Prechild Diversion Project. I'm a therapist, and I just wanted to respond to what you were saying, Cassie, regarding care teams. Prior to working with adults, I was working in early childhood, so I'm familiar a lot with the 0 to 5 initiatives and things of that nature. So hearing about care teams is like second nature in early childhood for you know, the critical ages. And I'm just as being a provider for adults floored that that doesn't exist for everybody else, because just as critical as it is for, you know, infants and young children, we do have other populations that are so in need of more inclusive and comprehensive dynamic care.
Thanks.
If I may just
Please
ask one question, really, and it goes really to your very early comment, Jocelyn, on the implementation. And I think several people have said this. I think one of the things that has been striking, and it differentiates the children's initiative from what I'm hearing about Prop 1 so far, it sounds to me that you have a structure with teams working under you, and I assume you have data that's coming in so that you can hold those various agencies accountable. Where is the accountability structure in the mental health side of this? I haven't heard that, and that was my hope. I don't know if anyone is left from the earlier session to comment on that.
Yeah, I'll just connect it to the managed care comments I made.
Yeah.
Through a series of policy decisions, the most recent being Prop 30, the state cut off its ability to effectively regulate county mental health plans. So, but the state has a direct contract with every single managed care plan. So to answer your question, the biggest reason I would, if you're Governor Newsom and you hire the best guy we got going in the state, which is Secretary Mark Galley, he's like literally the smartest dude you ever met. And the two of you sit down and you say, wow, we got the nation's largest Medicaid program. And guess what? It kind of sucks. We got to fix it in mental health. And we have two horses to ride. We have county mental health or the managed care plans. And we don't have strong regulatory structures in county mental health because we enacted Prop 30, which means we have to pay in advance for anything we tell the counties to do. Or we can rewrite our contracts, put them out to bid, and try to regulate the growth of the system through the managed care plans.
So who will regulate this? That is my question, Alex. There is a history, and very much appreciate that Jocelyn is addressing this in terms of both commercial managed care plans in behavioral health opting out, dumping people onto the public side. And oh yes, this has been taking place. I have been seeing it for the last 15 years in California. So if California is moving out of this and allocating the responsibility, whether it's public or private managed care, who is overseeing that?
The contracts are held by DHCS. The licensure is held by DMHC. So it's confusing, and there are serious questions about the state's skill and will in terms of ability to hold managed care plans accountable.
My hope is that CalMatters will, in fact, in the ensuing years, holding
Jocelyn will do it.
You're echoing exactly what the mayor said on his way out earlier. He said, what's next? Like, how are you guys going to start covering this? And he and Kristen and I had a conversation out in the hallway about that and sort of our role and the media's role in this, right? And as much as it should all be on CalMatters, let me quickly introduce Rob Waters. Rob's with an organization called Mindsight News, another nonprofit organization like us that relies on donors to support it. They focus nationally exclusively on this issue, and Rob's based here. Between Mindsight News, CalMatters, and a few other folks, we do intend to stay on this and keep this conversation going. We are, as I said, a nonprofit news organization. We rely on your contributions. Grateful for any support you can give us. Our newsletter called What Matters comes out every morning. It'll have Jocelyn's accountability coverage about this and everything else in it. You can get that at our website, calmatters.org. And our festival in Sacramento, June 5th and 6th. Love to see you there, calmatters.org/festival. Ask any one of us or reply to the email you got about this, and we'll give you a discount code to get in cheaper. Love to have the people in this room in that room, because that conversation about how we tackle California's biggest problems needs to have the people in there who care the most, and that's obviously the folks who showed up here today. I'm tremendously grateful to Nixon Peabody for hosting us. Lou, thank you. Beautiful facility. We're all going to just stay here for a few weeks if that's okay. It's a really nice place. The food's great. And certainly the sponsors, Sutter Health, Cal Wellness, and California Healthcare Foundation for helping us out. And to Dan Lewis, the Northwestern professor who put this whole idea together. Couldn't be here with us today. His student Layla's here with us representing him. We'll all say hi to him with a picture shortly, but who made this whole conversation happen. This is the start, right? We have a lot more to talk about, and we will certainly keep this going. Thanks again to you all for being here to do this. Thank you, everybody.